in any country, any state, or happy that this very apt, topic has been chosen with a lot of experience, people coming from all over India as an expert, and that we will, because we have worked together to see that maternal mortality rate is diminished. We tried our level best because the stakeholders, like people coming from CHCs, PHCs, dispensaries, and even the district hospital, because they are a part of the stakeholders and the people providing healthcare, especially in terms of maternal health, to the state, especially East Khasi Hills. And I'm happy that, the people who are involved with the maternal care are being invited and being a part of this program. And I would like to thank the Department of Ops and Gynae and Meghalaya State Government for organizing this. Of course, we have, as you know, what is us, and it can be delayed within even 4 weeks, So, of course, we have up to, of course, delivery, one vaginal, it's up to, I think, 500 ml is accepted as the PPH, and maybe on the cesarean, it's more, maybe up to 1 liter of blood loss is called PPH. And, it's a very important to see, of course, the causes that you see, especially as a radiologist, we're getting a lot of cases that is coming in when this way we have to do ultrasound. And we have, in fact, we have presented a case of PPH where there's a retained placenta using a color Doppler studies, we can pick up. And one very important topic which I was gathering from the colleagues and the colleague is that, the incidence of this cesarean is very high, because I was taught in a very good, my ops and gynae teachers are very, very, very strict towards, having a delivery as a patient, because a normal delivery is through vaginal delivery, But things are becoming simpler. It looks like it's a fashion to undergo a cesarean sections. So I was told by my colleagues in ops gynae that, cesarean section is one of the leading cause of having the placenta, the acrita, where is it, So I think that is very alarming, which I just want to focus a little bit on this, because, of course, post the cesarean section, because of the adhesion with the placenta along with the myometrium. So I believe this is the leading cause of placenta, the acrita, where there's adhesion between, so that's the reason why there's retaining flux. So I think, because my obstetrics and gynae experience and intern and the PG has been quite extensive, that we have to do round the clock. And I think the incidence of, doing a cesarean is not a normal way of cleavage between the placenta and the uterus. So I think some of these cases that can be picked up even during the ops ultrasound or ops examinations. And I think there are some cases which need to be referred. In these cases, if you suspect a case of acrita, and I think that has to be referred to a tertiary care center, a district hospital, or maybe in like NEIGRIHMS or tertiary care, where, so that we are anticipating the complications that can come that might actually lead to PPH. And so I think I'm sure with this exercise in the workshop that we're going to have, we will have a lot of experience coming in from our experts, coming in from all the way from Kochi, sir. Paniker, we have a lot of names. I could see even the Google that a lot of procedures and equipments are under your name with the patents. So we're proud of you, that we are happy to have you. And I'm sure today's workshop will be very fruitful. The delegates, all the best. Thank you very much.
Thank you, sir, for your encouraging words. I would now like to call our chief guest, Professor Dr. Vandana Rafael Ma'am, to kindly say a few words.
Good morning, everyone. Respected dignitaries, today's guest of honor, our Health Commissioner, Dr. Zoram, our Dean, Dr. C. Daniela, our Medical Superintendent, Dr. Animesh Mishra, and convener of today's program, Dr. Ananya, and all the faculty, invited guests, and the delegates. It's indeed a great pleasure for me that, I'm here for this inauguration function on this particular CME workshop on PPH. In the last week, actually, I saw two news items which I was very delighted. One was related to maternal mortality rate. Eastern states have very poor maternal mortality rate. But the news was that, From year 22-23, where it was 284 per lakh, it has come down to 100 per lakh in Meghalaya, which is very, very interesting. And I've been here past 20-25 years, and I know it was one bothering item in our state health indicator. Then the second news was like, that the ministry, the state ministry is not, just probably happy that they have achieved this, but they are going further. The second news was, there was a training program which happened in Chennai for the medical officers of Meghalaya for 6 months, all related to obstetrics care. And that was very delightful because I felt, okay, they are not sitting quietly because they have achieved something. They want to go further. They want to bring things down further. They want to improve the quality of the healthcare in our state. And in addition to this, today we have this program because we know one of the most important causes mortality is PPH, which is preventable, but in the rural areas still, this is one of the important causes. So today's probably the workshop and CME will help you how to tackle with this. Being myself from the Department of Pathology, I know when I came here, the blood bank facilities, for example, was very few and were only concentrated in Shillong. But over the years, I've seen the network of blood bank has improved and it's gone beyond. And I think because it is very stringent rules that is there to start a blood bank or even a storage unit. So Inspire managed to expand it to several of the districts of this state, and that is one of the important things which is required to tackle the PPH. So I'm sure with continued efforts from the state and from the center, we will be able to achieve that. And we here at NEIGRIHMS, being a tertiary care, I most of the time hear from our doctors that we don't get normal delivery cases here. Most of the cases we handle is all which is the high-risk pregnancies, whether people with a cardiac problem or associated some other renal problem. So these are the cases that come through, and rightly so, because we are a center, a tertiary care center, and we should be here to guide all those patients who need extra care. So with having a super specialties, having all the super specialists with us, I'm sure we are in a better position to deal with high-risk pregnancies. So with these few words, I congratulate the Department of Ops Gynae for holding this program in association with the state ministry. So congratulations, and I wish all the delegates to have a good knowledge and good discussion and good interaction to carry home the good message and practice it in your daily practice. Thank you very much.
Thank you, ma'am. I would now like to call our guest of honor, Dr. Joram Reda sir, to kindly say a few words.
Professor Mishra, Medical Superintendent, Professor Ananya, other resource persons, and students. First of all, it's good to be amongst doctors. I feel like I'm amongst my own colleagues for a change. And speaking today on this platform makes me feel like an ant telling the elephant how to chew grass, because all the luminaries of medicine and surgery are here. And with my very short clinical practice, I don't think I should be telling you what PPH is all about. But with the rigors of training in my medical college, which my senior colleague, Professor Daniela, will agree, that the undergraduate course that you remember medicine and surgery for the rest of your life. And with that, I do recall that PPH is all about using 500 ml of blood in a normal delivery and 1000 ml in case of cesarean. I also remember from the rigors of my training that the gold standard of management of pregnancy is the third stage. As Professor Daniela was mentioning about the retained placenta, I do recall during my undergraduation days an internship, how a small negligence would have led to a major case of PPH because of retained placenta. There are also instances wherein there are clots, and many times we think these are small clots. But during pregnancy, post-delivery, if we are not careful, you will see, clots the size of your palms. And these clots can also lead to PPH. There are n number of issues of causes for PPH. I'm sure you'll be studying in Obs and Gynae. But the question is, when it comes to a field practice, like in case of governance, who decides that this is a 500 ml of bleeding? Who measures it? Because majority of our deliveries are not institutional, unfortunately. Significant number of deliveries are still at home. Who decides that this is 500 ml, this is 1000 ml, or, every woman post-delivery will be to some extent hemodynamically unstable. Who decides that this is clinically significant? And this is the reason why in our field practice, from the administrative point of view, when we review the cases of maternal mortality, the beyond the walls of classroom things are very different. So we always find this PPH as one of the major cause for the maternal mortality. And there is a lot of information asymmetry. In our tribal societies, by nature, we are very resilient. So most women will say, "Arey, chale, we can just get it done at home. We're tough." But that toughness is, that attitude is what leads to these kind of issues. And that's where the changing of attitude is very important, and having such kind of CMEs, not only for the practitioners, also for the administrators, is very, very important. So beyond classroom, in classroom you will only study about the technicalities, but the actual implementation on ground is very different. So doctors will have to go beyond the theaters, beyond the OTs, and also try to raise awareness about all these issues. I always say this: the womb of a woman is the first home of every human on earth. And it's very important that the future of a nation is decided in the womb of a woman. And it's very important to give, the whole focus of governance and administration should be to preserve and protect that women's health. And it's very important that through this CME, we should understand the nuances of how to implement all the things that you study. So it all boils down to that 500 ml of blood loss, and how to convince, how to teach, how to let women know the importance of institutional delivery, so that any kind of intervention can be done at the crucial hour. So I again repeat that the gold standard of management of pregnancy is in the third stage, and that's why the importance of institutional delivery. I'll not bore you with a longer speech, because today's CME is all about listening from the resource persons. So I'll conclude my speech here, and I hope you take back home good message. Thank you so much.
For your encouraging words. Finally, I will call Dr. Ananya ma'am for a vote of thanks.
Good morning once again. First of all, I'd like to thank the Almighty for giving us this wonderful opportunity of having the scientific event here today on an important topic, and that too with stalwarts. On behalf of the organizers, I extend my heartfelt gratitude to our chief guest, Professor Vandana Rafael ma'am, for her presence here in spite of a very busy schedule. I would now like to thank our guest of honor for today's function, Dr. Joram Beda, Commissioner and Secretary of the Health and Department, Government of Meghalaya. I also thank Dean Sir and Medical Superintendent Sir NEIGRIHMS, along with the whole administration, for the support they have always provided. Special thanks to our guest faculty, Dr. Vasudev Paniker Sir, who has come all the way from Thrissur, Kerala, to enlighten us on this important topic. I'd like to mention here that there cannot be any PPH workshop without Paniker sir. Our special thanks also goes to Dr. Rita Bhuya ma'am, who took out time from her experience and could make it to the CME here today. I'd like to thank the District Health Society, NHM East Khasi Hills District, for their cooperation, especially our District Maternal and Child Health Officer, Dr. Lisa, the District Medical Health Officer, Dr. Momin, who was supposed to be here but couldn't make it for some urgency. I'd also like to thank the Meghalaya Medical Council for the credit hours which will be granted to the CME. I would now thank our departmental colleagues and all other faculties of NEIGRIHMS for their support. I'd be failing my duty if I don't thank all the delegates who have come here from different health facilities in the district to attend the CME Come workshop. Thanks to all my postgraduate students, residents, interns, MBBS students who are the essence of the event. I'd like to thank the telemedicine staff for the audio-visual support and live streaming of the program. I also thank the photographer who would make the event memorable for all of us here today. I thank the caterers who would definitely energize us and keep the enthusiasm alive with their delicacies. I thank all other supporting staff of the event whom I might have missed to mention. Thank you one and all.
Thank you, ma'am. Now I will request all the dignitaries to kindly take their seats down. We'll be starting the session shortly now. I'll request all the delegates and faculties to kindly collect their certificates before they leave the CME today. Heading towards our scientific session, I would like to call our first speaker, Professor Dr. Ananya Das ma'am, to deliver her talk. Ananya ma'am is a professor of Obs and NEIGRIHMS with more than 16 years of UG and PG teaching and examiner experience. Ma'am has received AICOG 2010 CS Dawn Award, Yuva Foxy 2013 Young Talent Award, AICOG 2019 Srimati Bhagavato Devi Yamuna Singh Award, AICOG 2024 Champions Award. There are more than 75 publications in index journals and book chapters and has been an invited faculty for around 60 international, national and regional conferences.
A very good morning once again. So as we start with the scientific session for today, let's deep dive, okay? Let's take a deeper look, a very wide, extensive and intensive look into this global burden in women's health, and that cannot be anything else other than postpartum hemorrhage. So this scourge had been in the society since the 17th century. Yes, we are very familiar with this. This is Begum Mumtaz Mahal, who in the year 1631 died after giving birth to her 14th child. And she bled. She bled to death after delivery. And that is because of postpartum hemorrhage. We know the magnificent Taj Mahal, one of the 7 wonders of the world, was made after her death in her loving memory. But do we really need any more Taj Mahals which occurs after a death with PPH? And the answer is a big no, right? So a mother dies needlessly every 6 minutes from excessive bleeding after giving birth. So this is a very startling fact, a very startling truth, and it makes us baffled as well. We are perplexed with the situation, and we should realize that we should do something about it. There are moments to ponder. So when we look at the leading causes of maternal mortality, the leading causes, as we can see, are eclampsia, preeclampsia, ruptured uterus, prolonged obstructed labor, hemorrhage, sepsis, complications of abortion. Now, from this pie chart, you can easily make out that the cause which accounts for most of the causes of maternal mortality is nothing else other than hemorrhage, which is almost 1/4 of the causes. Now, even our International Federation of Obs and Gynae, they have also endorsed upon the fact that hemorrhage is the leading direct cause of maternal death worldwide, representing around 27% of maternal deaths. Now, that is a very significant number. More than 2/3 of reported hemorrhage deaths were classified as postpartum hemorrhage alone. Now, when we look back at the definition which was proposed by FIGO, it defines postpartum hemorrhage as the loss of more than 500 ml of blood within 24 hours after giving birth, or more than 1000 ml after a C-section. 20% of all maternal deaths reported globally are due to PPH alone. Most maternal deaths, though we know, are from the third world countries. You look at the facts and figures. Now, these are also 5.8% of women in their first pregnancy, they have PPH. The risk of a first PPH in second or third pregnancy is 4 to 5%. The recurrence rates are also quite alarming, with something around 15%. Now, a matter of grave concern is 20% of all maternal deaths reported globally are due to PPH, but in this statistics, we find a bit of relief. 54 to 93% of maternal deaths are preventable. So this is where we need to intervene, and believe me, we can actually bring a change in the rate of maternal mortality, because it's all about prevention, the way we understand and the way we take care. So when we look at the Meghalaya fact sheet as well, due to PPH, the deaths in the third quarter of 2023-24 is the number of deaths are 11. I mean, this is quite okay, but again, not acceptable. We have a bigger goal ahead. This is, I'm sure all of you are aware of the Sustainable Development Goals. Now, these are certain goals which are in place, and there's a plan of action towards it, wherein we actually look forward to a place on earth where there is a better economy, better health, where there's justice, there's equality, health and prosperity for all. The global maternal mortality ratio stands at 223 maternal deaths per 1 lakh, that is according to 2020. But SDG third goal, which is about good health and well-being, it calls for a reduction in the rate to less than 70 per 1 lakh by 2030. That is another 6 years. And no country should have an MMR which is more than 140 per 1 lakh. So this is something we have to achieve and we have to strive towards it. Now, keeping all these things in consideration, the WHO has convened a global summit on PPH in the year March 2023, wherein participants were drawn in from governments, ministries of health, healthcare professionals, non-government organizations, national and international societies, even the private sector, the medical device companies, pharmaceutical companies, wherein all inputs were taken and to decide the roadmap ahead. So we now have a roadmap to combat postpartum hemorrhage between 2023 and 2030. So 2030, the roadmap is from 23 to 30, and by 30 we should be able to achieve the SDG goals. So this is the PPH ecosystem wherein I have already mentioned people from different spheres are all working together to achieve it. And even FIGO has endorsed it and we have to do it. So the roadmap basically has 3 key objectives. We need to identify first the key priorities and actions required to meet those goals and objectives. Accordingly, we have to align all the stakeholders in the field and work towards it. The focus should be on key activities to remove duplication of efforts because it's a big task. We cannot waste our energy and resources on duplication. Engage stakeholders to urgently advance PPH work across countries. Now, there are 4 pillars, if we can see, in this roadmap. Number 1, which is of the highest priority, is research investments. Yes, nothing can be done without a proper research. Research investments into determining what works best and how it works best to deliver the proven PPH interventions. Now, for that to happen, we need developers of norms and standards, because as long as the norms and standards are not there, even good research cannot take place. So it has to be at global level, regional level, and national level, and we should continue to individually invest in very good quality research and fruitful research. After the research studies are available, those research will be of no use if there is no proper implementation at the community level. So implementation of effective interventions is further hampered by multidimensional barriers. We all know about it. So that should not extend beyond adoption of global norms. Advocacy initiatives by civil society and non-governmental organizations can be powerful catalysts for global action. Now, having said all that, you all must be wondering, okay, WHO is doing this, FIGO is doing this, what is my role as healthcare provider? We actually need to implement whatever standards have been said and laid down. So now what we do, every patient who walks into our labor room, that patient we need to assess for the risk of developing PPH, and we have a risk assessment tool which is very much standardized globally for us to decide whether the patient needs extra care, whether we really need to watch out for PPH or not. So now in the high risk factors, we have low risk, medium risk and high risk. We will put them according to the risk categories, according to the history and examination findings, and decide which patient needs utmost priority. Now, apart from that, we have categorized the risk, but again, we need to be prepared to prevent PPH. Now, the preparedness starts right from the pregnant women there should be a proper birth preparedness and complication readiness for pregnant women, family members, and service providers. And that counseling starts right from the point she comes for antenatal checkup. We don't need to scare her, but yes, of course, she should be provided with proper facts and information so that she can prepare herself accordingly. Adequate antenatal checkups and investigations is a must. Healthcare providers should be prepared with adequate number. At no point of time there should be lack of number of healthcare staff. Skilled and with updated knowledge. Knowledge is ever evolving. All the time we need to upskill and update ourselves. Emergency response team should be ready with team division. That is also important. We need to delegate, we need to properly distribute the work. Facility readiness is another thing. Traffic signal approach for triaging green, yellow and red, adequate infrastructure, appropriate equipments, the PPH kit, crash kit trolley, all should be ready in hand, because we just cannot be searching for things, making our trolley ready when a patient has come. Appropriate medications such as all uterotonics, tranexamic acid, everything should be available. Now, uterine balloon tamponade, non-pneumatic anti-shock garments, suction cannula, transvaginal uterine artery clamps, everything should be ready. Blood and blood products availability is a must. So that also we should check in. PPH checklist and debriefing forms are to be available and should also be available in the local language. Protocols and procedures are always in place. The partography monitoring is mandatory. Cardiotocography in high-risk situations is also important, because only then we can detect that the lady is a high risk and we need to take extra precaution for her. Active management of third stage of labor goes a long way in the prevention of PPH, and if actually followed, it can really cut down the figure of PPH. Use of safe birthing checklist and surgical safety checklist is also important. Now, can there be any non-clinical component in the management of PPH? Can there be any non-clinical component? We have talked about the clinical component. Yes, without the non-clinical component, clinical component doesn't actually work. There has to be a proper system integration. Mapping and linkage of low resource centers with tertiary care centers to minimize morbidity and mortality due to PPH. That is very important. We need to know if we are a low resource center, where actually we are going to refer when we encounter such cases. Facility readiness has always been important. It is for availability of PPH kit. Emergency response team should be there. There should be availability of transport for quick and prompt referral. And of course, we should check on our readiness every now and then. Teamwork and communication, that is the key strategy of every PPH center. Constitution of emergency response team along with clear alarm system. There should be clear role and responsibility of team members. Obstetric drills and simulation on PPH should be held off and on. We should evaluate our performance, and then continuous evaluation of competency of staff is also an integral part. There should be respectful maternity care, timely information to family, information, education and communication. The IEC material should be available for advocacy among beneficiary and family on PPH. A proper referral protocol needs to be in place. There has to be a clear understanding of what can be managed at the facility. List of cases which need to be referred, documentation and equipment required for referral. Trained personnel should be there who should be taking care during transport as well. There has to be again a timely information to higher facility, and well-equipped ambulance should be there for proper referral. There should be clear delegation of roles and responsibilities of each healthcare worker during referral. Quality improvement is another parameter where we need to focus along with quality assurance. Problems should be identified and we should find solution by the team. Data recording and analysis is also important. There has to be proper standard data management. We should always be monthly or quarterly reviewing our data of PPH related indicators and keep on assessing whether we could improve on our past performance. Maternal death and maternal near miss data review is also must. An inventory management system for PPH kit, because of course we cannot run for things when the patient has actually arrived. Advocacy is the last thing but not the least. The various models should be tested for PPH management. Whichever model we find successful should be replicated in different settings to control PPH. Now, clinical components we'll be discussing with the speakers later in the course, but let me just tell you in brief, there's 0-hour management, the first response bundle, refractory PPH and supportive care. Now, when you look at this slide, you'll know that AMTSL is something, active management of third stage of labor, which we really cannot get away with. I mean, most of our problems are solved if we can really follow active management of third stage of labor. The first step is in management, when we actually encounter a case of PPH, is always call for help. We should not be shy in doing so. We should actually call for help, because PPH management cannot be done by one person. First response bundle, in the first response bundle, we have the uterine massage, which is a continuous thing. We have the IV fluids, which have to be taken care of, uterotonics and trinaxamic acid. In supportive care, if it's a case of traumatic PPH, we need to treat the tears, empty bladder, empty uterus. Refractory PPH interventions, we have compression, we have uterine balloon, and we have the anti-shock garments. Supportive measures are always there, which go on along with. So it is the transfusion, referral system, if proper management is not possible in the index facility center, and surgery is the last resort. Now, there are certain best clinical practices which we need to follow. PPH prevention, I mean, all of us know prevention is better than cure. So with PPH prevention, we really, whenever a patient is embarking upon pregnancy, anemia needs to be corrected. So that is one thing which goes a long way in prevention of PPH, and early detection of PPH is also important. We should be able to identify the previous and current comorbidities which can lead to PPH. Birth planning and complication preparedness, both for the woman, the healthcare provider, and the facility, is very important. The first response is early recognition and excessive bleeding. So that means, to manage PPH, the first thing we need to identify whether she is having PPH or not. So this is very important, and once we have identified that it is a case of postpartum hemorrhage, we need to monitor the vital signs. We need to ensure that she gets back to her hemodynamic stability. Laboratory testing, of course, these are important, and we should get the blood grouping and cross-matching done immediately. We should also look for the completeness of the placenta when removed, because these are certain things, these are very small things, and if we can really put a checklist on all these small things, we can again prevent PPH. Reassurance to woman and her family that everything is being done, and time to time, it's not that once the patient comes, she has PPH, you just inform the attendants and the patient once. That doesn't serve the purpose. They have the right to know time to time change in the status of the patient. Now, whenever the case becomes a case of refractory PPH, we should inform the woman and her family of treatment options available. We should provide reassurance, continue monitoring, surgical management, and then we have the balloon tamponade and all in place. If a woman continues to bleed, the last resort is, of course, hysterectomy. Now, all of us know that the International Federation of Obs and Gynae, they have worked relentlessly to provide the highest standards of women care globally. Now, for PPH also, they have done, the PPH working group has done, along with WHO initiative group, they have done a lot of research and tried to formulate things properly. And they have offered AMTSL for the prevention of PPH. Now, every skilled attendant, according to FIGO, should be trained in AMTSL and in the techniques and treatment of PPH. Every health facility where births are taking place should have adequate supplies of uterotonic drugs, equipment, and protocols in place. Blood transfusion facility is a must for every center which is dealing with deliveries. Physicians are trained in simple conservative techniques such as uterine tamponade, compression sutures, and devascularization. But today in our class, we'll know, something even simpler than this, and which can really go a long way in preventing deaths due to PPH. The study of promising new drugs and technologies, member countries are surveyed to evaluate the uptake of recommendations. Now, in PPH management, even if you have the whole army of doctors with you, you have whole infrastructure with you, it doesn't serve purpose much, because what is important in PPH management is timely management. So time is the essence of management, and if you lose that time, then whatever things you have in place in hand, it doesn't serve the purpose really. So keeping this thing in mind, there has been a trial, which is a randomized trial for early detection and treatment of postpartum hemorrhage, and it goes by the name of emotive trial, and it has been published in the New England Journal of Medicine on May 9, 2023. Now, this is a multi-country parallel cluster randomized trial with a baseline control phase along with mixed methods and health economic evaluations, wherein they have covered more than 2 lakh women globally. Okay, and so that they are not just considering the developed world, they have also tried to include 4 low and middle income countries like Kenya, Tanzania, Nigeria, and South Africa. So they have taken 80 health facilities, and for the first 7 months, what they have done is all the 80 facilities were put on the usual care. And after 7 months, for the next 7 months again, they have divided those 80 facilities into 40 which were getting the intervention of emotive, and the other 40 which were again continuing with the usual care. Now, the primary objective was basically, the primary objective was basically to evaluate the implementation of the emotive intervention compared with the usual care. And the secondary objective was to assess the cost effectiveness of the emotive and develop, optimize, and manualize an implementation strategy with parallel process evaluation alongside the trial. So from this slide, you get a fair idea of what is emotive. Now, E stands for early detection and trigger criteria, wherein what is being done is calibrated drape for blood loss collection with trigger lines at 300 ml and 500 ml for the first hour after birth is used. And then we have to constantly observe the lady for blood loss every 15 minutes and document it on the monitoring chart. Now, the trigger criteria are clinical judgment in the sense that pulse and BP will be altered with more blood loss. And we have those in the drape. It's a transparent bag blood collection where there is a mark at 500 ml and 300 ml, which will itself raise a trigger. Now, M is for massage of uterus. We massage the uterus until uterus has contracted. O is for the oxytocin drugs, which we are using regularly. 10 units IV oxytocin diluted in 200 to 500 ml of crystalloids over 10 minutes. Over and above that, we need to maintain a maintenance dose for 20 units IV oxytocin diluted in 1000 ml saline. Trinaxamic acid, T is for that, and 1 gram IV injection of trinaxamic acid diluted in 200 ml crystalloid over 10 minutes we can give. Then trinaxamic acid can also be repeated another dose if within 30 minutes the bleeding doesn't stop. Now, IV fluids in addition to the infusion should be given if clinically indicated for resuscitation and will require a second IV access as well in most of the cases. Now, the last E in emotive is for examination and escalation. This examination and resuscitation continues throughout the procedure. We ensure bladder is empty, evacuate clots, check for tears with an internal examination, and placenta, as I told, we should always look for the completeness of placenta removal. Escalate if bleeding does not stop after first response or we are unable to identify or manage cause of bleeding. So this is all about emotive trial. So this is again a quick recapitulation of the emotive intervention. Now, the primary outcome in the trial which has been sought for is whether in which group the postpartum laparotomy for bleeding until discharge from the health facility was more, in which group the postpartum maternal death from bleeding until discharge from the health facility was more, and if any of the components occur, this will be deemed as positive for the primary outcome. The key secondary implementation outcomes were the detection of postpartum hemorrhage and how much each of the groups could adhere to the treatment bundle. So this is the result of emotive, and it's quite impressive. I mean, when you look at the first graph over there, you see in the intervention, the severe postpartum hemorrhage, laparotomy for bleeding, maternal death, everything is 1.6 around, but in the usual care group, it is 4.3. So it is almost 4 times. And the detection of postpartum hemorrhage is at a significant percentage of 93.1% in the intervention group, whereas in the usual care, only 51. That means when we are following the usual care, then 50% of the cases, we are not being able to diagnose only that it is a case of postpartum hemorrhage. Adherence to treatment bundle is 90% again in the intervention group. So this trial, the landmark emotive, was led by University of Birmingham researchers and coordinated by the Birmingham Clinical Trials Unit, and has been awarded the David Sackett Trial of the Year award by the Society of Clinical Trials in 2024. Now, what is important to recognize here, it's not about just because WHO has taken up the study, it gets the clinical trial award of the year. It's not that. The main thing is the trial has used something which is feasible in a low resource setting, and it goes a long way in prevention of such a global burden, and that is PPH. So that makes it the best clinical trial of the year. Now, the conclusion of emotive, as I said, they have seen that when objectively measuring blood loss using a simple low-cost collection device called a DRAPE and bundling together the WHO recommended treatments rather than offering them sequentially. So mind you here that whatever trials and interventions we have discussed in the emotive, it doesn't happen sequentially. It has to be started as a bundle in one go, and then we get the results. So it has gone a long way. It has reduced severe bleeding by 60%, and women were less likely to lose life because of PPH. So finally, to summarize, childbirth is a very joyous moment for every woman and her family. So we should ensure that there should not be any death of woman which is premature. Of course, during childbirth, if she is dying, it is premature death, and no baby should be left without its mother. Let's pledge today to save mothers and to stop PPH. Thank you, everybody.
Thank you, ma'am, for such a comprehensive talk. Now heading towards the much awaited talk by none other than Dr. Vasudev Paniker, sir. Though he doesn't need any introduction, he is the former National Coordinator, Indian Medical Association, Maternal Mortality Prevention Cell. Sir has invented over 15 surgical instruments, many patented, and innovated 15 surgical and treatment techniques, many of which are life-saving. He has been invited as faculty in many international conferences and conducted live workshops and presented papers in many national and state conferences. He is the author of the book Life-Saving Intervention in Obstetrics and Gynecology, and hold awards like M.A. John Award and Dr. C.L. Jhaveri National Family Welfare Planning Award. Sir.
Good morning, dear friends. Dr. Ananya Das. It was by God's grace. I happened to meet her in one of the conferences, and by chance we had a talk, and then she invited me to come over to Meghalaya, Shillong. It's by chance and by luck. I have to come to Guwahati yesterday evening. I am a faculty for the state conference of Assam tomorrow and after tomorrow. I came one day earlier to come over to Shillong. See, a lot of theoretical portions you heard about PPH, but as on today, What I'm presenting is a simple method to prevent and treat PPH. Am I audible? Because mic is little far. By near 100%. I cannot say 100% because it is not proper to say 100%, but it is 100%. To prevent and treat PPS, no woman should lose 500 ml of blood during vaginal delivery or 1000 ml during cesarean section. Why should they lose? They should not lose any blood. Maybe 10 ml or 15 ml they can lose. So we can prevent any blood loss during childbirth. That is possible. Let us see how we can do it. I am coming from Kerala, the other part of the country, and I am having a small hospital, 15-bedded maternity hospital. I was in government service. Basically, I am anesthetist. After anesthesia MD, I did DGU. It is out of my curiosity because when I did anesthesia MD, my thesis was obstetric analgesia and anesthesia. You may be knowing obstetric anesthesia. When I prepared for the thesis in obstetric anesthesia, I read many books. Many of the Western books were written by anesthetists who had qualification obstetrics also, like Jonathan, Moyer, Crawford, and many like that. So I had an ambition to have a DGO to become an obstetric anesthetist later. But I did DGO after MD, but government posted me in smaller centers, primary health centers and community health centers, where I have to work both as anesthetist and gynecologist, and I worked like that till my retirement. After retirement, I started my hospital. It is 20 years, more than 22 years now. Then, because of my anesthesia, now you can hear me? Because of my anesthesia knowledge and working experience and background, I was bold enough to do in the smaller setup all procedures without fear. And whenever a difficulty comes, I try to overcome it with some innovative ideas. Many ideas and I have put forward, and many instruments I have made, many procedures I have made. And now, today I will be presenting a simple innovation that can prevent and stop PPS by near 100%. This is my place called Kodungalur, a small township in Kerala. Sorry. Yeah. These are all the instruments that I have made. These are all the procedures that I have made. I have nearly 15 instruments patented. I have got 13 patents, 3 are waiting. We can make everything in India, beloved Prime Minister. These are the instruments that I have made, nearly 20 instruments. This one is the PPS cannula. Only one model is needed. I have made 4 models and one single-use cannula also. I cannot explain everything because of loss of time, and we are focusing mainly on PPS today. This is the PPS cannula. This is a stainless steel cannula. This is 12 millimeter in diameter and nearly 25 to 30 centimeter in length. Always connected with a silicone tube with a connector, because it can be used in any emergency situation. We can keep it autoclaved or sterilized ready. And this can be used for vaginal delivery as well as for cesarean section. So I keep the cannula always ready with the silicone tube. It's very inexpensive. The making charge is nearly less than 2,000 rupees. I am giving it 2,000 rupees. And it can be used for many number of years. This is a single-use cannula. This can be used single-use cannula. Used for anyway. I am connecting with the silicone tube for this also, so it can be used for during cesarean section. I will show you how it is being used. This is another wonderful instrument I have made. This is super bipolar forceps. I made it nearly 20 years back and perfected it. I made it mainly for doing sutureless non-descent vaginal hysterectomy. You might have heard of that. Now we have good quality company made biclamps with which you can do sutureless hysterectomy, but 20 years back it was not there. I am the first person to do sutureless hysterectomy. For that I made this instrument. This is a wonderful instrument. This can coagulate and even divide any vessel or any tissue. And for PPH also this is very useful, especially for placenta previa surgery and other surgeries. Even for cesarean section, to stop bleeding, I am using this instrument. This is a wonderful instrument. This is available only with me, that's the problem. This is also a right angle forceps. I have made a 60-degree curve behind, so its ergonomicity and handling efficiency has enhanced many times, so it can be used as an aneurysm needle and a forceps to tie vessels at depth. I'll show how I am using it. This is a cervix dilator. This is the usual cervix dilator you have seen, Egas dilator. You can dilate the cervix up to 6 centimeters easily. After that, it's difficult. But with this dilator, you can dilate even up to 1 centimeter or even up to 1.5 centimeter very easily. All of you use it and see the difference. Sorry. I don't know how it came. No. Where's the video? Videos? I have videos on this. Anyway. Oh. Doesn't matter. Just 1 second more. You have selected the placenta previa slide. You close, select the PPH one. Yeah. No. This is the placenta previa. This one. Yeah. Keep it. Sorry, that was the opening slides for the placenta previa surgery. This is my presentation is say goodbye to PPH mortality. That is by 100%. The first slides are common. Okay, I will. Yeah, this is how the PPH cannula works. The PPH cannula is introduced into the uterine cavity. Whenever there is PPH or you suspect PPH or you want to stop PPH, you can during vaginal delivery remove the PPH. You can just do PV with 2 fingers and introduce the cannula into the uterine cavity to reach up to the fundus. Then connect it to a suction machine. Of course, the machine should be leak-proof and start suction. When you start suction, the uterine cavity will contract, uterus will contract, and the cavity will become empty, and the cavity will become narrower and narrower, and it will strongly suck onto the cannula. The surface of the cavity will strongly suck onto the cannula, and all the bleeders will be closed by the pressure of suction. We allow 20 minutes, so clotting happens in all these smaller vessels that are bleeding. That is the inner wall of the inner surface of the uterine cavity. That is the placental surface. From the placental surface only PPH happens. So all the bleeders will be closed, and after 30 minutes you can switch off the suction machine, or if it is a manual suction, you just release the suction and make the pressure to 0. Slowly you can take out the cannula and there will not be any further bleeding. In difficult cases, I have kept the cannula for 3 hours, 4 hours, and this procedure will work not only in atonic PPH, in all PPH, irrespective of what is the cause. Even in DIC and even fulminant DIC with amniotic fluid embolism, I have kept the cannula for 2 days to correct the DIC, and the patient was saved. So it is possible. Everybody should try this, and you need not study the theories. Theories are all for the examination. For practical purpose, this is the one tool that you require to prevent and stop PPH. Of course, I have shown this one. This one. This is the manual unit of Ventus. You might have seen this one. I will show it. I will demonstrate it. This is the simplest one, costs nearly 2,000 rupees or so. Advantage is that you can keep the negative pressure nearly 700 and stop pumping. It will remain like that if it is leak proof. You have no expense. Without electricity it works. You can shift the patient if you want. You can take it to any place. Even if it's a home delivery, you can use it without any danger. You can see how much blood is collected, and you can know whether PPH is stopping, because blood will not trickle once the PPH has stopped. Very handy and very useful, very inexpensive one. You see this video. It is the audio.
This is a PPH cannula innovated by me. This is 30 centimeters in length and 12 millimeters in diameter with multiple holes. This can prevent and stop PPH with almost 100% success. This is made of stainless steel. This can be used forever, and it will save all our mothers from bleeding from the postpartum uterus due to any cause. And this is useful even in DIC and patients with PAH. Kindly use it. This is quite inexpensive. See how I am using it.
This is a case of severe PPH. I am using Paniker's PPH suction cannula to prevent and stop PPH. Introduce the PPH suction cannula into the uterine cavity by vibrating the anterior lip of the cervix and then the internal wall. Make sure that the cannula has reached up to the fundus. Then connect it to a suction machine to make a negative pressure of 700 millimeters of mercury. The blood collected in the uterine cavity is sucked out first, and the wall of the uterine cavity will be strongly sucked onto the cannula, and the pressure of suction will stop all the bleeding, and 30 minutes is allowed so that all the bleeding will be stopped by the pressure of suction and clot formation. This case was severe bleeding, so I put the cannula before suturing the episiotomy, and this is very comfortable and convenient to suture the episiotomy if you put the cannula before suturing them, because there will not be any bleeding from inside the uterine cavity, and you can very comfortably suture the episiotomy. This is a breakthrough invention to prevent and treat PPH with almost 100% success. Total blood loss in this is nearly 200 ml. Thank you.
Now I will show you a case of cesarean section. It's a previous 2 cesarean section with 9 grams of hemoglobin. I usually don't give blood transfusion. I don't have facility also, and I don't keep blood also. I'm now confident enough to tackle the situation. This is cannula. This is a silicone tube connected, and I always keep this autoclaved and ready. You see how I am doing using this PPH cannula during cesarean section.
Friends, I am here demonstrating how to use PPH suction cannula during cesarean section.
Keep a PPS suction cannula connected with a silicone tube like this, water fluid and ready. Please see the video. See the uterus like this. Don't suck or bite the uterine cavity. Hold the lower edge of the incision, uterine incision with the two Alice forceps and then insert a dilator through the pores to check the fertility. Then introduce the silicone tube which is already connected with the PPS cannula like this. It will go into the vagina and an assistant can pull the tube down through the vagina and connect it with the suction machine. Just gone down, then like this, introduce into the uterine cavity and make sure that the cannula has reached up to the fundus. Now, hold the edges of the uterine incision with Alice forceps together like lower and upper together like this. And immediately you can start suction and you can feel the uterus contracting. Suction started. See the uterus is contracting, it has become pale also. This stony hurt now. See this one? So in whatever the work of PPSC, even in placenta period, you can, after removing the placenta, you can do like this and the pressure will be saved. See the stony heart. See the rugosity and start suturing like this and close the uterine incision. This is the uterine incision after suturing. Cannula is inside. Now we can put the uterus inside the abdominal cavity. Lift the joints and put inside the abdominal cavity.
Less than 100 ml. In a previous 2 cesarean patient with 9 grams of Inaugural. So you can prevent PPS. That's why I wanted to show this blood loss also. This is the manual unit of Windows I use for suction. I have similar videos. I cannot fast forward it because my things have changed. It will take time when I show other videos. If you want to see, I will show you. This is a case of placenta previa, type 3, anterior placenta previa. I have done cesarean section, removed the placenta and exteriorize the uterus immediately. One mistake we do when cesarean section, you unnecessarily mop the uterine cavity and suck the uterine cavity. Don't touch the uterine cavity or suck the uterine cavity. To check whether the cavity is empty, put one of your fingers, 1 or 2 fingers, and just sweep and see whether uterine cavity is empty or not. Otherwise, don't disturb the clothes, don't disturb the, because bleeding stops by clot formation. Once you wipe with the cloth, all the clots will be gone and bleeding starts again. So don't touch, don't suck. This is the cause of all the adhesions, infections, and all the placenta previas. I have 40 years of experience. I attend many conferences, not only gynae conferences, other subjects. I am very active in this field. IMA, there are private hospital associations, even other disciplines I go. So I have learned a lot practical things. Newer thinking is that don't suck or mop. It will be harmful for healing. You take out the clots with your hand and don't suck it out because the serum that is left is PRP. It will facilitate healing. So, this is I told you, this is a type 3 anterior placenta previa. Anyway, I will show the video full.
previous two cesarean section, one negative patient with anterior placenta previa, cesarean section done, baby is taken out and the placenta also removed and uterus is externalized. The lower border of the uterine incision is held with 2 or 3 Alice forceps like this, and the patency of the cervical canal is tested with the dilator, and then the PPH suction cannula is introduced into the cervical canal. The silicone tube is introduced first, and an assistant can pull down the tube from the vagina out and then pull down further the PPH suction cannula. This single-use sterile PPH suction cannula. Introduce the PP into the uterine cavity to reach up to the fundus like this. Yes, like this. Make sure that it is touching the fundus. Now, close temporarily the uterine incisions by holding it with the few Alice forceps like this. Both the edges of the incisions are held together. Always the assistant should keep little pressure upwards so the cannula will remain touching the fundus till the suction is started. Now the suction is started. You can see the uterus becoming smaller, the color of the uterus becoming blanched and pale also. It has almost become stony hard. This will stop all the bleeding from the uterine cavity immediately. Now we can close like this. I am using number 1 bicycle to close the uterine incision. That's a lower segment with the engorged veins because of the placenta previa. Uterus is put inside and the abdomen is closed. This is the suction unit I am using. You see the blood dose, it's only nearly 150 ml. For such a difficult cesarean case, third cesarean with placenta previa. Everybody can do this and be successful. Don't be afraid of PPH or placenta previa. Thank you.
We'll show one more case. Are you getting bored with these cases? This another case, previous cesarean section. That's also a poor lady with 8.5 grams of hemoglobin, and I wanted to prevent any blood loss in this lady. So I am using PPH cannula during cesarean section, but there's a peculiarity I will show how I am using it. This is the cervix dilator. I hope you may have noticed in my instruments group. This is a cervix dilator. I will show how the cervix dilator is being used.
This is the new cervix dilator in. This can be used to dilate cervix for all purposes. Here, during cesarean section, when you want to introduce the PPH cannula and the cervix is not dilated, you can use this instrument to dilate the cervix. Like this, you introduce the dilator through the incision, uterine incision, and pass through the cervical canal, and then press on the body of this instrument. The tip will expand and then you rotate, the cervix will be dilated. Up to 1.5 to 2 centimeters you can dilate. Then it will be dilated. Then you introduce the PPH cannula and connect the suction machine and make a negative pressure and PPH will be fluid. This is a very, very useful tool for all obstetricians for in all cases where you want to dilate the cervix. Just do it under anesthesia when you do a DSC. Thank you. This is a previous cesarean case with the O-negative patient again with 9 grams of hemoglobin. I want to put PPH suction cannula during cesarean section. The cervix is closed, and so I am using cervix dilator invented by me to dilate the cervix. See? The cervix is dilated. We have to use it few times to dilate the cervix when the cervix is tubular. This cervix is not that tubular, so I am using only 2 or 3 types. In very difficult cases like uneffaced tubular cervix, you may have to use few times to get proper dilatation, so that you can introduce the PPH suction cannula. First you introduce the silicone tube connected to the PPH suction cannula, like this. It will go into the vagina and assistant can pull down the tube through the vagina, like this. And this is single use, sterile, lubricated PPH suction cannula, innovated by me. Now you can close the uterine incision. Make sure that the cannula has reached up to the fundus. Assistant should exert little pressure upwards so that the cannula will remain touching the fundus always till the suction is started. The uterine incision is closed using few Alice forceps like this. Now the suction is started. You can see the uterus contracting. The color of the uterus become pale. Size also become reduced. You can see it has become almost blanched. And see the color of the uterus. You see the blood dose, practically 50 ml or so in a previous cesarean section and negative group, 9 grams of hemoglobin. Thank you very much.
Blood dose is practically nil. So there is no need that the mother should lose 1000 ml of blood in C-section. No. This is a new thing I am telling. I am not saying that I am a great person, nothing like that. See, our thinking has to change. Theory is not practice. Theory is only for the examination now. So, all of you can do this. I told you I am working in a very small setup. I do a lot of innovative things because basically I am an anesthetist, I have courage to do. But I am imparting this knowledge so that everybody can do. I am imparting this 30 years experience or 40 years experience, both as anesthetist and gynecologist, so everybody can. Ordinary gynecologists may not be bold enough to do such things. But now I have perfected it, so everybody can do. Don't be afraid. You save the patient. No facility needed. This is all about PPH cannula. I have a lot of other videos, but that I will show you. Do you want me to talk on placenta previa? No, that I will show you afterwards. This is all placenta previa. So, and this I will complete later also. An idea can save millions. I say like this because ever since the beginning of human race, our mothers are delivering. That's why we are here. There was no treatment for PPH in the earlier days. Millions of mothers would have lost their life. But no mother would lose their life anymore. That's why I said millions in the future would be saved with this simple innovation. This is a quotation from Bhagavad Gita. Yedita jarishrashasta deveda rojanaha sayat pramanam gurde devastan vardute. Whatever a great man does, the other man also do. Whatever he sets as the standard, the world follows. This, the world will follow. Never stop learning, because life is teaching every day something new. For the talk of PPH, I am closing here. This is Professor John Goodenough. You may be knowing him, you may have heard of him. He got Nobel Prize at the age of 97 for inventing lithium and battery. He passed away last year at the age of 100. We are all very young people, do innovations and try to get Nobel Prizes. Thank you very much. Don't hesitate to call me. This is my mobile number. It's available everywhere in the YouTube. You click Dr. Paniker in YouTube, it will come. Dr. Paniker gynecologist, it will come. And you can call me at any time, even at midnight. Don't hesitate to call me for whatever you needs in PPH or anything, any doubt. You call me, I will answer you. Yogasanastha Subhiro. If you want me to talk on placenta previa, then I will continue with that or? Huh? Then come on, give me that. Other questions.
Sir, PAS was there, sir. Placenta accreta.
I will show. I will show. This is also very simple, innovative idea in managing placenta previa, either for cesarean hysterectomy or for uterus saving procedures. You do a simple hemostatic suturing. There are many techniques of hemostatic suturing. I forgot to tell you one thing. Once in the PPH section, once you use the PPH cannula, there's no need for any compression sutures, any other intervention. Don't spend time on compression sutures. If you are doing cesarean section, immediately you can put the PPH cannula and close the wound with a few eyes forceps and start suction. Problem is finished. Don't go for compression sutures and lot of blood is lost and sometimes patient is being lost and lot of complications will arise. So I don't say don't use, but it is not needed actually. Compression sutures or stepwise devascularization, not needed actually. I will tell you why it is. So this is cesarean hysterectomy or uterus saving procedure in placenta accreta spectrum only. Other placenta I have shown you, you can take out the placenta, immediately put the PPH cannula and close the incision temporarily and start suction. By 1 minute you can do this. No need to bother. But when there is a placenta previa, if it's a little major degree, always think that there may be an adherent portion, that accreta portion. All accretas are not 100% covering the entire placenta. It may be a portion, maybe 1/4, maybe 1/3 or a half. But you must suspect that in major degree, especially previous cesarean section, there may be an accreta portion. So take precautions for that. I will tell you how to take precaution. The slides are common. In this also common in the this I will skip because this is common. Yeah, this is the standard diagram in the internet. Standard qualification for placenta accreta spectrum. Actually, we are afraid of it. We don't have to be that much afraid because once you diagnose the placenta accreta by ultrasound or by MRI before, then you can take precautions. Otherwise, whenever you suspect that there may be accreta portion, you do cesarean section and take out the baby. Don't touch the placenta. Even if we say that placenta accreta spectrum, this accreta that is just entering into the myometrium is 75 to 78%. Then ingreta, that's going deep into the myometrium and reaching up to the serosa is 17%. And only 5% is percreta, that is going beyond the serosa, and sometimes it may be infiltrating into the bladder if it is an anterior placenta previa, especially linear previously. Then it can even invade the mucous membrane of the bladder, or even very rarely it can go inside. By this 5%, everybody is afraid to tackle placenta previa. But You can do it simply. Anybody who is capable of doing cesarean section can do this. I will demonstrate how you can do it. This is a picture of a postpartum uterus of a placenta previa. This is placenta previa. This is a previous cesarean section patient. This is the previous cesarean scar. Again, this is the incision which we make for doing cesarean section. I have done cesarean section and taken out the baby, and this is the umbilical cord. Usually, I don't, not at all, not usually, in my practice, I don't clamp the umbilical cord on the placental portion, because I will let out the blood, so the placenta will not be that angry. In vaginal delivery also, I do this. People are afraid that you may lose too much blood. No, placenta is baby's organ. It will not lose any blood even if it is accreta. So I do like this. And then exteriorize the uterus completely without touching the placenta. So you make a little bigger incision. You can do it with transverse incision. Don't go to vertical incision and do a lot of things like that. You put a transverse incision in the beginning and you exteriorize the placenta. When you exteriorize the placenta, this will be the picture, this will be the anatomy you see. Uterus is huge. This will be the fallopian tube hanging down. This will be the ovary hanging down. Inferior ligament hanging down. This is a broad ligament, and you see the ovarian vessel hanging down like this and going laterally, and this is the uterosacral mechanoidal ligaments, and here will be the uterine artery going up. And then this is the bladder. If the bladder is adherent, don't try to push the bladder. There will be vascularity and there will be too much of bleeding. If the bladder is not adherent, you can push the bladder down. If the bladder is adherent, keep it there. Then take 2 pieces of number 1 Viper like this, nearly 30 centimeters in length, at the tip of the PUL forceps that I have shown you. Instead of this PUL forceps, you can take a 6-inch artery forceps or a mosquito forceps. Take 2 pieces together like this, and then just above the bladder, at the center, on the cervix or the lower segment, you need to both pierce from anterior to posterior at the center like this. You can turn the uterus. On the posterior, you can see the tip of the cervix, the tip of the forceps, and open the forceps and take out the threads to the posterior side. Then, with the anterior counterpart, you tie like this. You can tie as tight as possible and as low as possible. The thread will not go further down because of the uterosacral ligament here. It will occlude all the blood vessels going into the uterine cavity. All the blood vessels. Not even a drop of blood will go into the uterine cavity again. So your patient is saved. This will take only 2 minutes. You can do it very easily. Don't be afraid. There is nothing else to be afraid. Ureter is far away, bladder is far away, everything is far away. By this, you have saved the patient. All of you understood what I say. Could you get the anatomy like this and could you grasp this? When you do cesarean section next time, observe like this. You mimic this surgery. You can do, even if it is not placenta previa, you do this suturing in 1 or 2 cases, then you will be confident. Nothing will happen. This is only a puncture site, just like a needle prick. Even if there is some oozing, you put a suture there to close it.
Do you have a live video of this?
Yeah, I will show that. I will show that. I want to explain it before, that's why I explained it. Everything is in. I will. If you are bored, tell me. Otherwise, I will tell everything. Then you can do, after the suturing, you can do either cesarean hysterectomy. If you want to do hysterectomy, start from here, clamp and cut and suture. I usually coagulate. My bipolar will coagulate everything. And at the end, you reach here. Close the vault. Then release the suture and see whether there is any bleeding or not. If bleeders are there, either coagulate or suture it. Then cesarean hysterectomy is finished without blood loss. Because from above the suture, there is no blood loss, there is no bleeding. If you want to preserve the uterus, then you take out the placenta. If there is an adherent portion like this, dissect out that portion and take out the placenta. Then, with the adherent portion, you take few figure of 8 sutures going into the myometrium, or you can go even up to the serosa and take 10 or 15 sutures you can do like this on this dissected portion. I will show that one. Dissected portion. And then slowly release the suture on that side or both sides. Then you can see whether there is further oozing or not. The uterine incision is not closed, you must remember that. If there is oozing, then you can introduce a PPH cannula like this and temporarily close the incision and start suction, and everything will be, bleeding will be finished. Or what I am doing, I coagulate with my bipolar, everything will be over by that. Any bleeder, it will coagulate. Then you close the incision. Then again, I put the cannula because it's for additional safety. 100% it will not bleed. Then, if the lower segment is very bad, you can put many sutures. Only if it is adherent to the bladder, then the problem comes. Then again, you can suture like this and call for help, or you can even send the patient with, or you can observe the patient if there is bleeding. One patient where I did a subtotal hysterectomy, it was a long time back. After suturing like this, I did a subtotal hysterectomy because placenta was going into the bladder. Then the patient started bleeding a little bit afterwards. Then it was spinal anesthesia. I do myself under anesthesia, everything. I don't want to disclose my secrets like that. She started bleeding again. What I did vaginal, the rest of the stump I did vaginally without any difficulty I did. This is all possible under the same anesthesia I did. Because uterus is taken, so the stump is very mobile. You pull it down, open the pouch, bladder is adherent, but vaginally you can dissect the bladder very easily. So it's possible, it's not possible by all, anyway I have done it. It's also possible, that's why I said. So, coming to my next slide. This is how I said. This is the placenta accreta portion. You dissect out the placenta, remove the rest of the placenta, and then put few hemostatic sutures and remove this suture. And one more thing you can do, if you don't have any other, you are not able to do PPH, introduce PPH suction cannula, you have removed the suture, there is bleeding, you put another suture through the same puncture site. In that case, you take one thread on the left side and one thread on the right side separately. I will tell you why it is so. This yellow thread is like that, for that. Then, medial to the ovarian vessel you take it. Medial to the ovarian vessel. And tie it as tight as possible on both sides. This will stop all the bleeding. But the ovary will get the blood supply. And some blood supply to the uterus also will be received, and bleeding, there it will not bleed because you have put the suture like this. Understood what I mean, what I am telling? You take another suture like this, and medial to the ovarian vessel you put the suture. So you can leave the suture and close the abdomen and leave the patient. Nothing will happen. I will tell you why it is. This suture, you take one suture at a time like this, one left and one right, because the thread will not entangle each other and the cervical canal will not be closed. the cervix will be opened. Understood the point? And this is a hemostatic suture. Many people are doing hemostatic suture. This is another form of compression suture without compressing the uterus. There is a Gideon suture you might have heard. One lady is from North India. She is just suturing like this. Medial to the ovarian vessel, just suturing in one or two places in cesarean section to stop the bleeding and leave the patient like that. She has done hundreds. She has presented a paper and she said, till now no complication was said. Then you have head of Dr. Mahesh Gupta. He is doing a lot of surgery for placenta previa, uterus saving surgery. He has a special technique, special needle, special suture. What he is doing? He is piercing the needle somewhere here and suturing like this on both sides, leaving the ovarian vessels. Nothing is happening here. He is doing hundreds. So there is no harm in doing a suture like this. You can do this also. Try this when you are doing cesarean section next time. And after that you take the suture and go back. If at all there is a music, you put a simple suture there. I hope you understood everything. I will show. I have these sponges are with me. I will show that also. This is how I put the PPH cannula in these cases. This is the result of PPH cannula when it is introduced into the uterine cavity and started suction. All the contents are sucked out and the inner wall of the uterine cavity is strongly sucked onto the surface of the cannula and the uterus will get contracted. And one more point I will tell you. Outside the uterine cavity, there is the normal atmospheric pressure in which we are existing. This is the normal atmospheric pressure. Here it's a huge negative pressure, 700 millimeters of mercury. So there is a huge pressure difference between the two. The principle of nature, whenever there is an inequality, it will try to equalize. So the pressure tends to equalize, pushing the uterus inwards. Because it's a uterus is a muscular compressible organ, the muscles are compressed onto the cannula, thereby closing all the vessels and compressing the uterus, and uterus cannot go atonic again. This is the mechanism, that is physics involved in this cannula. Understood everything? I will show you the suturing. I will first show you an animation for better understanding. Is it too much so everybody can follow?
Here I am demonstrating a special suturing technique for uterus saving surgery in placenta previa and glanders. Transverse uterine incision is made above the level of the placenta and the baby is delivered. The placenta is left undisturbed. This is the PUL forces invented by me. It has a 90-degree curve at the tip and a 60-degree curve behind. This can be used as a thread carrier as well as a universal needle. This is the postpartum uterus exteriorized. The uterus is pulled anteriorly to expose the UV fold. UV fold opened and bladder put down like this. Two pieces of number 1 micron 50 cm in length is taken at the tip of the PUL forceps and it is pierced from anterior to posterior side, just above the bladder at the center of the cervix to reach the posterior side like this. And the tip of the forceps open and the threads are pulled out and the forceps is taken back. One thread is taken to right side and the other is taken to left side and tied on either side as low as possible and as tight as possible. This will occlude all the blood supply to the uterus, including the ovarian vessel, uterine artery and its branches. You can see the uterus becoming pale and the vessels are
getting shrunken. Now you can proceed on to hysterectomy or uterus saving procedures, and when completed, you can remove the hemostatic suture and check for any bleeding and close the abdomen so that the ovary will regain its blood supply also.
This is the technique of hemostatic suturing. I will show you a short video, actual hemostatic suturing.
Now I will demonstrate hemostatic suturing in the case of cesarean section. Two pieces of number 1 radical 50 centimeter in length is held with the tip of the table forceps like this. The UV fold is open and the bladder is pushed down, and the PUL forces with the thread and the tip is pierced from anterior to posterior side like this. Now this is the posterior side, that you can see the tip of the forceps, open the forceps and pull out the threads. Take out the forceps and take one thread to left side and tie as tight as possible and as low as possible. This will occlude all the blood vessels, including the uterine artery and its branches and the ovarian vessels. You can see the round ligament, infundibulopelvic ligament, and the ovary there. Tube also is there. The same thing is repeated on the opposite side like this. Now all the blood supply to the uterus is occluded, and you can go on for obstetric hysterectomy, that is cesarean hysterectomy, or uterus saving procedures also. You can see the tight knot there. Not even a drop of blood will be going into the uterine cavity. And so this can be finished within 1 to 2 minutes and the life can be saved. Only thing you have to use is PUL forces for successful suturing.
Case of type 4 placenta previa acquita, where I was doing cesarean hysterectomy. I will show the steps. I have opened the abdomen by transverse incision, made a incision above the level of the placenta, and delivered the baby. This I am delivering the baby. I have cut short the video.
This is the uterus taken out with the adherent placenta, you can see it. And now I am opening the UV fold and pushing the bladder down. You see, small bleeders are coagulated with the super bipolar forceps that I have invented. Now I am piercing from the anterior to the posterior side with the vehicle held at the tip of this Paniker's universal ligation forceps. That is PUL forceps. This is the posterior side. I am pulling out thread bag. You can see the bulging posterior placenta there. I am taking the thread on the right side and tying it very strongly as low as possible. The same procedure is repeated on the left side also. I am tying on the left side as low as possible and as tight as possible. This will cut all the blood supply to the uterus, and then you can proceed on to your hysterectomy like this. You see the bulging lower segment on the posterior side. This is a super bipolar forceps I am using for hysterectomy. I am dissecting out the upper segment with the adherent placenta. You can see the placenta is still adherent there, but there is no blood supply. What you see is the bleeding from the specimen only. Total blood loss was nearly 1 liter. I gave 1 unit of blood to this patient, and her hemoglobin again came to 11 grams postoperatively. This is the specimen dissected out. This is the lower segment. It's all shrunken because no blood inside. Now I am coagulating the stump and desiccating and removing the lower segment. Also, inside you can see this is the lower segment. There's no blood supply, so it's very safe. to dissect it. This is the dissected lower segment. You see, totally dissected out. After dissecting, the stems are closed and the vault is closed, and then the hemostatic sutures are taken away and checked for any bleeding, and abdomen is closed.
I didn't show it fully because I have shortened the video and I cannot control it here also. Otherwise I would have shown you better, little more better. I have many videos, but I think this is enough and more. I will get bored and confused. This is the technique I follow. It's quite simple. Everybody can do, that's why I said. This is a long video, I cannot cut short it. It's more than 5 minutes. Same thing on another case. You want to see it? It's 5 minutes. Don't get bored.
Here I am demonstrating a special hemostatic suturing technique for cesarean hysterectomy without blood loss. This is the postpartum uterus exterior. You can see the engorged uterine vessels and its branches, as well as the ovarian vessel. This is the PUL forceps invented by me. It has a 90-degree curve at the tip and a 60-degree curve behind. This can be used as a thread carrier as well as an aneurysm needle. This is the postpartum uterus exteriorized. The uterus is pulled anteriorly to expose the UV fold. UV fold opened and bladder pushed down like this. Two pieces of number 1 vicryl 50 cm in length is taken at the tip of the PUL forceps and it is pierced from anterior to posterior side, just above the bladder at the center of the cervix to reach the posterior side like this. And the tip of the forceps open and the threads are pulled out and the forceps is taken back. One thread is taken to right side and the other is taken to left side and tied on either side as low as possible and as tight as possible. This will occlude all the blood supply to the uterus, including the ovarian vessel, uterine artery and its branches. You can see the uterus becoming pale and the vessels are getting shrunken. Now you can proceed on to hysterectomy or uterus saving procedures, and when completed you can remove the hemostatic suture and check for any bleeding and close the abdomen so that the ovary will regain its blood supply also. Only thing that you have to use is PUL forceps for quick, effective and successful completion of the surgery. Now I will demonstrate hemostatic suturing in a case of cesarean section. Two pieces of number 1 vicryl 50 cm in length is held with the tip of the PUL forceps like this. The UV fold is open and the bladder is pushed down, and the PUL forceps with the thread at the tip is pierced from anterior to posterior side like this. Now this is the posterior side that you can see the tip of the forceps. Open the forceps and pull out the threads. Take out the forceps and take one thread to left side and tie as tight as possible and as low as possible. This will occlude all the blood vessels, including the uterine artery and its branches and the ovarian vessels. You can see the round ligament, infundibulopelvic ligament and the ovary there. Tube also is there. The same thing is repeated on the opposite side like this. Now all the blood supply to the uterus is occluded and you can go on for obstetric hysterectomy, that is cesarean hysterectomy, or uterus saving procedures also. You can see that tight knot there. Not even a drop of blood will be going into the uterine cavity, and so this can be finished within 1 to 2 minutes and the life can be saved. Only thing, you have to use this PUL forceps for successful suturing.
This is the placenta previa cesarean hysterectomy I am doing.
This
This is
is
the great
another case.
type for placenta previa, anterior placenta. You can see
I have already
that is the
planned and cut the coronal
is
stitches and
hemostatic
implanted
suture. I have
You
already
see the
put.
rest of it.
I have clamped and sutured the coronal structures and the uterine artery. Now I am removing the uterus. This I am opening the
The bladder is a suture.
UV fold and taking the cutting of
It is
cutting
type
and
for
removing
anterior
the
placenta previa.
uterus. Because of the hemostatic suturing, there is no bleeding. What you see is the bleeding from the specimen only. I am cutting through the uterine tissue and the placenta. See, there is no bleeding at all because of the hemostatic suturing. I am removing the adherent placenta and the uterus. See, the adherent placenta bits are being taken off, and there's not even a single drop of blood is coming because of the hemostatic suturing. All the bits are taken off. The infiltrating bits are being coagulated with the super bipolar. I have invented. Any tissue or any vessel can be coagulated with the super bipolar. This is you can see the super bipolar now. Yes, this is the super bipolar. All infiltrating bits and bleeding points are coagulated with the super bipolar. And then the vault is closed. After closing the vault, the hemostatic suture is taken off, so the ovary will get the blood supply also. And again for a check for any oozing, and after abdomen is closed, after putting in drain. The super bipolar is a wonderful instrument. It can be used for all surgeons for all surgeries. Thank you very much.
Up to this, any doubt I can clear, then we will proceed afterwards. I don't have good videos of uterus saving surgery because all these are done in emergency situation without any previous calculations. So these are very with difficulty I recorded. See, earlier there was no good mobile also. Now we can record in iPhone. Very good picture it gives. I had many cameras, one by one, and my sisters are doing this because single-handedly I am doing all this. Still I managed like this. I have nearly 50 videos in the YouTube. Many of them are really good. I don't say all of them are good. Most of them are really good. Good educational value, and everybody can see it. It's very easy to see it. I have got a notice like that with a QR code. You can scan the QR code and see the videos in the YouTube. I have good number of viewers in the YouTube. Many of the videos are seen by more than 1 lakh, 2 lakh people. One of the video is seen by 1 million viewers. This I am showing. This is only a picture of ruptured uterus. Recently in Kerala, so 2 patients, mothers lost their life due to ruptured uterus. It was in a medical college still. When you rupture uterus, of course, if the baby usually the babies will be in the peritoneal cavity. Open the abdomen, take out the baby, externalize the uterus, put a hemostatic suturing like this. 2 minutes you can do. And the patient is saved. Even if she is gasping, she is saved. The anesthetist will infuse a good amount of fluid and resuscitate her. But if you go in for hysterectomy, lot of bleeding will be there, and the patient, many times you may lose the patient. This happened in Kerala. That's why I took a photograph from the internet and want to show you. You put a hemostatic suturing like this, everything is over. So again, an idea can save millions. Other things are common. Yes.
Thank you, sir. Now I would like to call Dr. Ananya ma'am to kindly felicitate sir.
These are the videos that are given in the YouTube. There's a QR code on this notice, and you can scan the QR code. I have only few copies. Rest, you can take the photocopy of this one, or you can even get it printed, and you can scan the QR code and see the videos. You see the videos many times. You will get a lot of ideas and you will be better than me. I hope everybody will be better than me. I am a pretty elderly person, and we have to go from this place.
So we can distribute all this.
Yeah,
It's okay, sir.
then this is my booklet. I have only two copies. This is my book. I have this book also. This is also copy I am sharing to everybody. I have address of everybody. I got the address from the office where there is a just as a service. I am sharing. So, I will share the book. New copies are shared in a company. Different copies are only two. This is most of the videos are very good. All of them are not so. Very funny.
After we have learned so much about PPH, we'll try to look at a few case scenarios and who can do it better than Dr. Rita Bhuyam ma'am, who is our next speaker and will be sharing some case scenarios. Dr. Rita Bhuyam ma'am is currently working as a consultant at Akanksha Hospital and is a former associate professor from Assam Medical College and Hospital, Dibrugarh. Please, ma'am.
Presentation.
Good afternoon, everyone. I'm thankful to Dr. Ananya for giving me the opportunity to come here and listen to Dr. Paniker sir, such a innovative and so we'll learn. We have learned a lot of things from you, sir, and it will help us to save lives. I was the nodal officer for maternal mortality in Guwahati Medical College for more than 10 years. And a woman, when she dies, it hurts you a lot. And so PPH is something which is preventable. And motherhood is what? Motherhood is a family. Motherhood means love. Motherhood means joy. Motherhood means contentment. And this motherhood should not turn into something which becomes a tragedy. And so all of us healthcare providers have a role to play to make this event a joy one. So today I'm here to just, everybody sees cases, everybody comes through cases. So we'll just discuss some cases only. So this was a lady, para 4, Gavita 4, para 3. And she, after she delivered, she has a lot of bleeding, and she was diagnosed as primary postpartum hemorrhage. Before coming here, I talked to the nodal officer in Guwahati Medical College, and she said during this, from January to October, there were 3 deaths from primary PPH. And the first, one case was referred from Goalpara. She was a case like this case only, and because she was a Gavita 4, she delivered, so nobody took much importance, and she had clots in her uterus. And she was sent from so far away to Guwahati. By the time she came here, she was in shock and she could not be revived. That is sad enough. Why a lady who has delivered so many babies without any uneventfully, why she has to go through this? What is the reason behind a multi-Gavita falling into trouble? This is because the number of times she gives birth, Gravida 1, Gravida 2, Gravida 3, Gravida 4, they become confident. And nobody takes much care of her, and she herself. Why a lady dies? First is the lady herself. She doesn't take care of herself. The family, they do not take care of her. And then us, we will like to improve ourselves. So what is our role? When she comes to us, we have to not check her blood pressure and her pulse and her fetal heart. We should try to tell her that what should be her hemoglobin percentage. So 11 gram of hemoglobin should be the target. You eat this, you take this, you have to motivate her only. So when she comes to you next time, when you ask, what is your hemoglobin percentage? When she tells you with confidence, madam, it has become 11. So you compliment her, and like this, a little bit of interaction from a little bit of our kind words will go a long way to save a mother. And so as the number of pregnancies becomes more, the hemodilution of pregnancy becomes more, the size of the babies become bigger, and so a lady who had delivered easily will now have an obstructed labor and all the complications. So the management part I will not discuss. So management part we all know, but what is important is the prevention and prompt diagnosis and management. Then this is another case where we have been always taught, when the placenta is delivered, we have been taught about active management of 3rd stage of labor. So active management of 3rd stage of labor, everybody knows, and we should not be in a hurry to deliver. Let nature take its own course. Like the placenta, the uterus has worked hard, the uterus has delivered a baby, let the uterus gain its tone again and push when the uterus becomes hard, it's pushing, then only we start giving controlled contraction and the baby is delivered, not before the placenta, the uterus has come, the contractions has not come. And when the placenta is delivered, it's just a small maneuver to just see the placenta, and there can be a successful globe also. So if we take these measures, so things like this will not happen. So this is again so much preventable. So when we augment labor, whether we do it's a precipitated labor, whether it's an instrumental delivery, so the little thing, what we see the uterine contraction, and we can do a vaginal examination and just feel the cervix. And if there is bleeding, then it is always mandatory to find out that there is no laceration in the cervix, there is no laceration in the vagina, and there is no periurethral tear. So once the delivery has occurred, the patient goes to the bed. Things should not happen like this, so that you don't have to bring her for repair again. Everything should be done in the labor room table itself. So this is another case. Again, we talk about draining for a long time. So if the patient comes with draining for a long time, so there is likelihood that the patient may have chorioamnionitis, and chorioamnionitis is a very important cause of postpartum hemorrhage, whether it is a vaginal delivery or whether it is a cesarean section. So whenever we are suspecting chorioamnionitis, we have to use broad-spectrum antibiotics, and we have to keep in mind that this lady is likely to have postpartum hemorrhage, and keep ourselves ready to manage. So we should not be in a position, because we say postpartum hemorrhage is an event where it can happen to anybody, and help and teamwork is the key to it. So again, a patient post-cesarean section pregnancy, yes, the cesarean section rate should come down. Cesarean section, whenever somebody asks me, madam, which is good, normal delivery or a cesarean section, I always say normal delivery is the best. But then in Assamese people, I have seen this in Bengali people also, they are always about normal delivery. They feel it's very painful procedure. But it's the extreme men in the north. North people, the day they come for the checkup, they always keep, I want a normal delivery. It's always opposite. Here, if everything is normal also, they want a cesarean. There, if everything is not normal also, they want a cesarean. So why this happens? Because this is a psychological thing. So suppose a lady has a cesarean section before, and she delivers a pretty big baby spontaneously, then she starts having bleeding, then we should always suspect that it can be something to do with the scar, and go to do an immediate laparotomy and take care. So again, the morbid condition. Another case which died due to PPH in Inaugural Medical College this year, she had this postpartum hemorrhage, she had jaundice, IUD, and all blood factor irregularities, and this is a multiple pregnancy, over-distended uterus. We must be careful. So another important is precipitated labor, sudden delivery. So again, we have to be careful. So this is because of coagulopathy. Again, prompt action. A doctor's wife, he himself is a gynecologist. They went to Calcutta for giving an interview in Magor. And then she developed hepatitis there. She delivered a baby. The baby was IUD, and she developed PPH. She died. A doctor dying with everything was there, and this is because of coagulopathy. We should always keep that in mind, and we should take precautions from before. Another very, very common thing is that patients, they come to us with prolonged labor. When I was in medical college, they are referred from outside with prolonged labor. So what I tell, whenever a patient comes in labor, it is a habit of the doctor on duty to do a PV examination. The paravaginal examination should not precede a parabdominal examination. First time we'll have to do a parabdominal examination to find out the folds. So if there is a big caput, then the caput will be somewhere low in the vagina. So in such circumstances, they are taught that this is going to deliver. They do an instrumental delivery, and all the things, rupture uterus, baby death, with PPH. So whenever a lady comes to us in labor, the first thing we have to see is a parabdominal examination, not PV examination. And that will prevent this postpartum hemorrhage and the immediate transfer of the patient to a center. Now, sir talked about placenta accreta spectrum. So today we came to know about this hemostatic suture. So previously, I have not done cases like this. Whenever we see a case of, I have been till now, I have come this far away, in medical college also, in my private practice also. So whenever I have got patients of placenta accreta spectrum, I have made an incision in the upper segment. I have always made it. First I pushed the bladder down safely, then made an incision in the upper segment, take the baby out, and then immediately go for the cesarean hysterectomy. So I have not fallen into trouble till now, and the patients are safe, babies are safe. So counseling is always done before, and with this, successfully I have delivered. But I have learned about the suture now. So let's see. The next case, maybe I will try. So this is whenever, suppose in the periphery. Now ultrasonography, nobody does a delivery without an ultrasonography. So ultrasonography should always be done in a place where the radiologist is competent enough. Because nowadays, this doctor thing has become a business. It is more of a business, a good setup. I'll not name. The MD, he addresses the doctors and he says, our loyalty lies towards our shareholders. The first sentence he tells the doctors is, our loyalty lies towards our shareholders. Means you make as much money as possible for us. But our loyalty do not last towards our shareholders. Our loyalty always lasts towards our patients. It is always the patients to whom our loyalty should last. So if that happens, no mother is going to die. It is just a matter of small involvement. They don't need so much. They just need a smile. They just need reassurance. And they'll come to you. Everybody tells me, the day she said, Pakiza said, Madam, your fees is this. I went to show my dog yesterday to the doctor, to this veterinary doctor. He charged 2,500. And then her husband said, she has not increased her fees for so long. Because I am not a doctor of the elite. I am a doctor of the population. A lady who is, is down to, she's earning very little, she should have the confidence to come to me. Then only I can save. Otherwise, how can I? So this is when the radiologist should be good and he should be able to give us the level of penetration, how much is there. I have seen a case, sir, in medical college. So this placenta accreta spectrum. So I was doing a case in the next table, the other table, this was. All the departments were alerted. Our senior doctors were there. There was blood on the floor. It was bleeding like anything. The ureter was injured, but the lady survived. So it was like this. But because our knowledge of what it is, how to tackle it has increased, that is why it has become safe now. And in the periphery, if somebody opens for a cesarean section and sees that there are a lot of vessels in the bladder invading the thing, close it. Don't do anything there. You close the abdomen. If I don't do a cesarean section, if I don't do something, and I send the patient to the center where it is safe, I don't say, the people will not say that she doesn't know, they will be grateful to you because she has sent the patient to the right place. So anywhere in the periphery, when you are doing in a civil hospital, you may not be able to tackle up a case of placenta if you do not have that, it depends upon how much experience and how much service I can give. So this is placenta, because with the rising of cesarean section, placenta accreta spectrum will be, very, very much common nowadays. Another thing is, I think last month only, I have done this cesarean scar pregnancy. They come for abortion. One lady, she came for abortion, She came with her ultrasound report. She had a 10 weeks pregnancy. She doesn't want the second pregnancy. I counseled her. She said, no, I don't want. I saw the report and it was okay. I put the suction cannula and she started bleeding like anything. Immediately I took her to the OT, opened the abdomen. And so scar pregnancy I have done last month only, I think 6-7 scar pregnancies. So they are becoming so common. So before, that's why when we do on MTP, we should not be filling. So without ultrasound, MTP should not be done. It doesn't become safe. So in placenta, whenever we suspect a placenta acreta spectrum, we should take care of it so that patient remains safe and we remain safe. An undiagnosed case of placenta acreta, when found intraoperatively in a peripheral center, is wise to close the abdomen and refer the patient to a tertiary care unit for better management. So this is again retained placenta. So this is overdistension. This is PPS due to secondary, this is abruptio placentae. So this is, again I said, fetal death, jaundice. So what are the take-home messages? So all of you have encountered all the patients, all the cases which I have mentioned. Dedicated antenatal checkup is the first step towards defeating PPS. Dedicated antenatal checkup means it begins the patient, the family, the healthcare provider, everybody is involved. Correction of anemia during antenatal period should be given the utmost importance. Proper nutrition and counseling plays a very important role in this. So if you encourage the patient to know what is her blood group, what is her hemoglobin percentage, so they will definitely learn. Counseling both the patient and the husband for contraception plays an important role in preventing majority of PPS cases due to multiple. When I was in medical college, the ASHA used to bring the patient for antenatal checkup. Then I said, it's okay if you bring till around 28 weeks, but after 28 weeks, the husband should accompany. Because the ASHA cannot take care of her. So if the husband accompanies, then you can tell with the husband also. All pregnancies should be considered at high risk. As today Ananya said, low risk, medium risk and high risk. But then we don't know, a low risk patient can become a high risk patient at any moment. And know the 4 T's, tone, trauma, tissue and thrombin that all of you know. Know the risk factor which might lead to PPH. Never underdiagnose the case. It is always better to overdiagnose. Early recognize prompt management and teamwork is the key. Regular postpartum monitoring of uterine tone and bleeding is essential. What we do when I was working in medical college, we have our OPD from 8 o'clock. I used to start OT at 4:30 in the morning. So 4:30 I used to start OT and then I used to come to medical college at 8. I used to see the log. Never late, always I used to see the log. So what I used to do? We used to always mark the fundus. Always mark the fundus, so this is the height of the fundus. If the height of the fundus increases, that means there is collection inside. So the doctor there knows. So little small things. Whenever some people they have bleeding, so when they have bleeding, we sometimes give a pack in the anterior vaginal wall and keep it like that. So if we remove it after 24 hours, there is no bleeding. So sir said about the cannula. With our experience, we have said about putting a pack in the anterior vaginal wall. It will compress. There's sometimes when they go into labor and they deliver, the cervix is patulous like this. The cervix remains open. The lower segment is like this. So when we give a pack and we give pressure, after 24 hours, when you remove it, there is no bleeding. Thank you very much.
Thank you, ma'am. I'll request Dr. Ananya ma'am to please felicitate ma'am. I'm sure after all these 3 talks, House must be having lots of questions. I will request them to please hold on for some time, and most of the questions will be answered in our next session. Now heading towards our last session, that is Know from Experts. Paniker ma'am to please come and take a seat on the dais. Ma'am is the professor and unit head, Department of Obstetrics and Gynecology, NEIGRIHMS. Ma'am is ex-associate member, RCOG, and ex-sub-dean, Students' Affairs. Ma'am has written many papers published in international and national journals and has been a guide and co-guide to many PG students. Ma'am has co-authored many papers which received prestigious prizes at national and international forums and has undertaken many IEC-approved extramural funded projects. I will request Dr. Vasudev Paniker sir and Dr. Rita Buyam ma'am to please come up and join as experts.
Is not there?
I now request all the participants to kindly come forward with their questions on the topic of PPH.
Of questions, so many theories you have heard, so many things you have learned, new things, and something which you already know. So now your experts are in front of you. I would request to please come up with your queries and get it clarified. Okay? So whatever you are encountering in your day-to-day practice, if you can just come forward. Megha? Right? Okay. Yes. Where's the mic coming there?
So this question is for you. So I just like to ask you regarding the PPH cannula. So can it be done even in a country zone? PPH cannula.
Yes.
Yeah. Can we do it? I mean, can we practice that even in countries also?
Yeah, it can be practiced even by the paramedical staff. My staff members are doing it. I don't thought of. Once or twice we got wisdom, It can be easy to be bold enough to do. After 2 or 3 cases, you will be a master. It's very simple. Put your left hand above the abdomen and feel the uterus. Use the right hand and feel it is released up to the front. You can start suction. Adduct the leg of the patient. So there will be any air. Always adduct the leg of the patient. So vagina will close and there will be any. Suction for how long? Usually it is 30 minutes. Vertical suction, you see the meter, when it has reached up to 700 millimeters, you stop it. But somebody should be watchful that the meter is not falling. Otherwise it will freeze. You have to keep the suction at 700 for only 30 minutes. Why it is 30 minutes? So that all the bleeders will be floated. And because the uterus is remaining contracted for that much period, there will not be any further bleeding. So somebody should watch. Don't leave the
Does it
patient.
require any training for the doctors?
Is very small. I was seeing many doctors from North India also were coming to place for NDAs and his labor training. But after COVID, I stopped because my kids are also even though I was working, I was nearly more than 100 years a month. It is only 20 So I don't have patients to do training time be. I cannot forecast when the patient comes and ask the patient to come. So I have stopped.
So that means in your video study something what you showed. So that's a part of like you can use those videos and you be showing.
Everything is there. Everything is there. That is it. You see that you try in patients, any doubt, any complications or any difficulty in patients, you call me directly. Don't hesitate. If I am in India, I will take a call. Only few occasions I go abroad. Otherwise, I will be here, even at midnight, or don't hesitate to call me. I will attend your call and give you the answer. Even if I am doing a surgery, my sister will take care of keeping for me.
And
This is my mission.
thanks. Another question, Madam, talking about present Krita and all. Since now we are having lots of cases in East Khasi also, we already have 2 other units in this rehab for Krita. So like we said, for this population should be done at the tertiary hospitals. Because these sort of cases don't happen even in the private hospitals. Because private hospitals, they don't have a bus storage in the sense that they don't have a supply. They allow only 4 units of that in their facility. So in this case, that means how do we get these private hospitals to send the patient to the tertiary?
Because my hospital is a private hospital, we don't have that. But Apollo is excellent care is nearby. So that whenever they want to that they request and the doctor who is looking after the hospital, the name is very, she's a very lovely lady and she understands the patients, emergency. So the thing of placenta, particular placenta equivalency, no expertise. Whether you can handle it or not. Suppose a lot of patients they come to me, they see my area and come to me for cancer. And then I said, I'm not a cancer surgeon. So I'm always refer the patient but I need to give the best service to the patient. So I was somewhere else where they can get good care. So if you feel that yes, blood is the second factor. Blood is not the first factor. And when you put your blood, it comes second. The first comes the expertise, whether you are confident enough to handle this case or not. Because this comes with experience, Maybe when you are in private hospital, you get the number of patients which you get is not, they are not so much like this, cases. And, they will not, if you have not taken care of the patient properly, they will see you. So So that's why that we have to decide. Blood is secondary. Blood you can get 4 minutes, 5 minutes, 7 minutes. The better on the table you can take care of the patient. Because I don't know, before you should not touch the placenta. The first case of placenta equita, I still remember, we had a 10-year-old doctor. I was assisting I was a registered attendant. I was assisting my officer. So, when I saw the placenta there, I told sir, please proceed with the hysterectomy. I told sir, please don't try to save the uterus. He was my officer. But I told him, sir, proceed with the hysterectomy. It was very good boy. But sir, at he did not. He tried to remove the placenta. And there was a lot of bleeding. And it is just like it's just like what we say. So much of bleeding. So then there was bleeding and he closed up. Then I said, sir, see there is time. Remove the uterus. Then the patient was sir, he did not. He said that we did the cigarette was done around 2 o'clock, not 2 o'clock, 12 o'clock, and the patient was sent in the ICU too. And there is a bleeding, active bleeding going on, what will the ICU do? And the patient was sent to the ICU, and the patient expired. And I did not, we couldn't save her. Because sir did not listen to me, and I blamed myself because I couldn't I motivate him to listen. So she went in his eyes, she had a fear, she died in the ICU. So that is what is important, whether you can do justice or not. If you can do nicely, you can, whether you can decide the better nicely down, take up the baby, upper segment, take it out, and then immediately proceed for a hysterectomy. You have to keep assistant dose competent enough. No, there is no problem. This is not about blood. Blood comes second. First comes your experience. Thank you.
Thank you so much, ma'am. So whatever message we get here is, expertise is really important. I mean, if you feel we cannot handle the case, maybe timely referral is the key to management here. So ma'am, I would like to ask you something further, I mean one step ahead. Like suppose you said the bladder can be easily mobilized and we can easily go ahead with hysterectomy. I agree to all of it, but what if the bladder is also involved? I mean, we do get cases of placenta creta where the bladder is also involved. Then, do you seek the support of urologist who is available?
Yes, we have a urologist in health hospital. He is always, whenever we are in trouble, whenever we see a bladder involved, we have to come and he is always here. Till now, thank God, his service was not equal now. But then whenever we open up, we always say, this is the thing you have to do. After his, according his timing, according his availability, only we can get this. If he has to come, then he has to be free.
So it's always better, like whenever we get placenta creta, it's best diagnosed in the antenatal period so that we can plan the case properly. It should not be an emergency. Of course, in unfortunate situations, we do get emergency cases of creta. But whenever it is diagnosed beforehand, we can get all the multidisciplinary team available and go ahead with the procedure.
I'll tell you about the case.
Yes, ma'am.
So there was a lady, she was not married at that time. So she had complicated menorrhagia. So she was referred to NEIGRIHMS. Dr. Henry, he expired now.
Dr. Henry.
Dr. Henry, he did a
uterine
embolization. Then she got married. So she got married and she was in Shillong. When she was 14 weeks pregnancy, she came with bleeding. So Saswati madam, she operated and it was that through the rent in the it was a perforation and she had bleeding. So she told the story. I had Dr. Rita madam. So every Saswati madam told me, tomorrow is Saswati. So I went to her and then I told her, you just don't get pregnant for around 2 years or so, but she became pregnant within 1 year. Then when I always told her, you stay in Guwahati. So I had got to Andaman. So I told I need my patients to leave Andaman. So I told, so wherever you are, anywhere you go, you tell her. The doctor, that my doctor calls me atom bomb. So I am an atom bomb and you talk to her. And this girl, every time I tell her, but she gave me pain at 34 weeks. She came to Varanasi home. She, Madam saw Upashana, she did an ultrasound. She said, there's something different. And I called the duty doctor, did anybody get admitted where I was there? And he said, 34 weeks, lady had got admitted. I also did not ask the name. Morning 6 o'clock, because I reached from Guwahati in the afternoon, I said, only one patient, that took down, she's okay, I will not be. I told in the morning at 5:36. And when I saw her, you did tell madam that I want you at home. She said, no. I said, immediately take her to the OT. Immediately I did a cesarean and the placenta had already perforated to the breast. So it was a good luck that she survived. So, so the patients are also, when we say about PPH, about preventing maternal deaths, the patient's role is so important.
Thank you, ma'am. So now since we are discussing about placenta accreta, so can we hear some more experiences from our other experts? Monica, ma'am, if you can please tell about your experience.
I would just like to share experience regarding diagnosis of placenta accreta. Because many times ultrasound people diagnose it as placenta accreta syndrome. So we keep it in mind when we have placenta accreta. And we try to arrange a OT daytime where me and my other faculty is there and lab products. But it is not necessary that every patient who is diagnosed with ultrasound and MRI is a placenta accreta. So we had 2-3 such experiences. So on the OT, we got gross examination. If you have a lot of vessels in your which support the diagnosis of placenta accreta, then it is wise not to try to remove the placenta and proceed with hysterectomy. However, if you see that on gross examinations, there is nothing different from the usual cesareans. Low segment is absolutely normal. Then I wait for some time and the placenta starts separating on its own and we proceed usually as we do cesarean. My only take would be that even if the ultrasound and MRI has diagnosed placenta accreta, please plan it accordingly, take all precautions. But try to correlate it with gross findings at that time during the cesarean, because grossly also there will be some extra vascularity if it is the case of placenta accreta. Because if you think it's placenta accreta, you will not wait for placenta to separate, you straight away proceed with hysterectomy.
But you can see, no? The blood vessels all across like this. It's a different look.
My only take is, as Madam is saying, when you have ultrasound or MRI diagnosis correlated at that time with gross examination also. So if you find this placenta accreta, don't wait for placenta separation, proceed with hysterectomy. But if you find that there are no grossly vascular something which is normal, you wait for 2-3 minutes, placenta will come out. So that we neither overtreat the patient nor undertreat the patient. Because another issue was with the timing of placenta accreta cesareans. People generally say go at 30 to 36 weeks. Our dilemma is it's only a radiological diagnosis, I cannot confirm it clinically. If I do it at 34 weeks and it's a bigger baby, and on table I don't find it is placenta accreta, we have unnecessarily taken out a bigger baby. Sometimes I try to take 2 opinions from a radiology. You think it is very sure it is placenta accreta. And nowadays also books are saying if everything is okay, take it to 36 weeks. So that we don't compromise on the baby. Because earlier the literature was saying you can do it at 34 weeks. If you do it at 34 weeks, but it is not a placenta accreta case, you have unnecessarily subjected the baby to premature release. So these are certain issues which I have.
Another thing, when we have type-free placenta, whenever there is a placenta locally, we say, immediate thing we see is whether it's anterior or posterior, whether this baby has previous cesarean section or not. Suppose it's a type-free placenta baby. So the placenta is expelled, but there is bleeding. So where will the bleeding come from? Placenta is separated, but still there is bleeding. The bleeding usually comes from the posterior reach. posterior reach of the uterus. So if you can see the visualize well and press it out to there, and you don't have to do unnecessary blood loss. Another thing what Sir was saying, that you don't put a mop inside and clean the uterus. Previously there was a habit, you can see, that when the baby is delivered, the cannula is always in a hurry, the hand insert. So, these are cesarean sections are very operational, they are not marathon basis. We don't have to finish step this time. So they have to be given their own time today. So I have seen a patient, she had a cesarean section, after that she had amenorrhea. A hot towel was put inside and the mopping was done, all the residue are finished. And after that, the husband said, I have a girl. You are dating me, mahina. So some small things, but those habits, I think the new generation people, they are very smart. They, they pick up and got so much access to the internet, so much access to things which are happening. So in those times, books were the things.
Thank you so much, ma'am. I think whenever we get information based on narratives, like she has been telling about patients, it creates a better impact, right? And we tend to retain it longer. So that is how it is. Now, sir, if you can throw some light on some conservative surgeries which we can do. I mean, we talked a lot about cesarean hysterectomy in placenta accreta. Now, there's something which is coming up now where placenta, the uterus needs to be preserved, and that is a placenta accreta. Now, you have been doing uterus saving surgeries as well. So, can we hear something about it?
Yes, uterus saving surgery can be done. Specifically, we need uterus saving surgery. My technique is like this way. Do a hemostatic surgery first. I told you, I am with different person. Whenever there is a doubt that this placenta can be adherent, if it is only a minor degree of placenta can be adherent, or whenever you take out the placenta, you feel some portion is adherent. Immediately you are hemostatic surgery. My instrument table is always equipped with PPH cannula and this like always. So whenever in doubt, I put PPH cannula and mother will not bleed. During cesarean section, I am saying. So whenever there is a different portion of the placenta, I chop out that different portion. I collaborate with the emperor if there is doubt of bleeding. Put hemostatic sutures and then release the first hemostatic, temporary hemostatic suture and see whether there is oozing or not. If there is no oozing, close the uterus, what is there? If you suspect oozing, put again the PPH cannula and close the uterus. Or you use another hemostatic suture that I showed you without including the ovarian vessels. Like that, you can manage. No need to do cesarean hysterectomy at all. Only in cases where the placenta is infiltrating into the blood. That is only 5% of all placenta accretas. That too, we can manage slowly dissect out the bladder, coagulating the bleeds. That all of you cannot do because you have to use good bipolar coagulator to dissect out the blood. As and when you dissect out, you coagulate these small bleeds. You can separate the blood. Because I am telling this, because I am used to my own practice. So I cannot make it a carpet performance. Even for doing NDBH, I dissect the intervaginal wall and dissect with the bipolar receptor. You might have seen that sometimes. There are early people do that. Nowadays, Purohit who is doing wonderful NDBH with bipolar, commercial, but he is also dissecting with the bipolar. Very few people do it. I started this from the very beginning because I am very confident in those things. I don't do dissection with the scissors. So, like that, you dissect the bladder up You coagulate and dissect, where is the chance? There is no chance of bleeding. Bleeding is from the placenta, not from the bladder. The placenta is supposed to be coagulating and going up. There's nothing to be afraid of like this. Even if there is some bleeding from the bladder, you can send the patient. If you are in a small center, you close everything, bleeding control. If there is oozing from the bladder, you send the patient to a higher center. They can, for great bleeding, it's not a great thing. You don't be afraid. Don't frighten others. To the gynecologist, what I have to say, you don't frighten the beginners. When you go, you do this, otherwise you will be caught, you will be penalized. In that case, I will be penalized 1,000 times. Because I have done very difficult things. When I will tell you one thing more. This happened, I have photographed all these things 2 years back. I did cesarean section for a twins. It was an IVF pregnancy. Poor patient. That's why she came to me after I went from a bigger center came to me. And she was all right till term, 39 weeks. I admitted her. She has little edema of her legs. Otherwise she was normal. I did elective surgery. It was like educated. Both pituitaries. And when I opened up, both the sacs were recording stage. Otherwise, there was nothing at all. Even, but prophylactically, I introduced the BPS cannula by closing, and there was no bleeding. Everything was all right. But after 3 hours after that, I removed the BPS cannula. I kept it for little more time. After 4 hours, she developed difficulty in breathing and collapsed. When I checked, BP was very low. Then I started noradrenaline dopamine. Then BP came up. Then her abdomen was tested. I did an ultrasound. I do ultrasound myself. I started 20 years back. Not in a big setup, but I do it. Then I had an analysis colleague, I called him, and immediately I opened it. Without just I opened. Found that there was Haemorrhage, and the blood was fluid red. There was not a single piece of body. Then only I understood that this is coagulation. Then I checked whether there is any bleeding points. The uterine stitch was intact. There was no bleeding points. Only small bruises on the cervical stitch. I cleaned everything, put it in drain, and referred the patient to a tertiary care center. She was in coagulation, she was engaged. They managed it nicely, I will tell you afterwards. This amniotic fluid embolism can happen even after some time. It may not have the pictures of cardiovascular plaque or lung symptoms. It can be fulminant lazy without any symptoms. That is atypical amniotic fluid. I don't know whether you are aware of that or you may come about it. I have read an article like that in the anesthesia journal for 7 years back. It was an review article. It is an extensive review article. There are many cases of atypical amniotic fluid. Even the babies that we come across after 2 or 3 days, patient is bleeding, it could be a minor degree of atypical amniotic fluid embolism, resulting in coagulation failure of different degrees. It may not be a fulminant affair. And this patient, I referred to a tertiary care center. They admitted in ICU, and she had liver failure, renal failure. She had not gone for a severe hypertension. She had hemoglobin was more than 7.5 grams always. But still, she went for liver failure and renal failure. And they managed nicely, and she was given nearly 100 units of blood products. And she came with all this after 3 weeks. After 10 days, she recovered from her liver failure. I don't know how she was liver failure for 10 days. Wonderful. After 10 days, she recovered from her liver failure. She is absolutely normal. But while saving the patient, I did this chemotherapy. So she will never be away on the way. Understood what I mean? You got the picture. I have quoted this in my book, this case history and the treatment also. Just for a knowledge. I have done nothing to it, but the patients. So, rare things can happen. You don't take rare things as example and try to do this. Yeah, that's right. You are obstetricians, you are saving knowledge. This is a government doctors. That's why I do like this, and I teach like this, and I hear this. It's a responsibility.
Thank you, sir. Thank you so much. So now, do you have any question? I mean, you want to ask something, how you really want to make your patient fit for referral? Yes, you want to ask something? No? I mean, since you are the obstetrician of primary contact in the PACs and CHCs, you receive a patient with PPH, I mean, how to make the patients fit for referral, if at all you cannot manage it at your center. We would like to have inputs from all our experts here. Is it that you want to know, or you want to add further to it?
I want to add some more.
Yes, please go ahead.
Good afternoon, respected members and guys. I'm one of the doctors working in one of the PACs, Khasi system. So the questions I'm going to ask are basically common problems are being encountered in the phase when we don't have much time to actually refer to a tertiary setup. So I have 3 questions actually. Since we were talking about the center data, I wanted to know if the rural setup, are there any predicting factors we can actually, are there any high risk factors or any sort of prediction that we can make during the KC period for women if they be prone to something like the center data? So the second question is, one of the common complications during the process for us in the field is retain placenta. So I'd like to know how we at the referee can manage such cases. And the third question I'd like to ask is regarding the PPH channel stuff. So I'd like to ask, can we use the PPH channel in cases of ambulatory uterus or as active bleeding, where the site of bleeding is not actually in the periphery? Thank you very much.
You mean the site of bleeding is a traumatic PPH or
like the electronic uterus?
It's a total perception problem. Any bleeding from the uterine whatever the cause, even if it's DIC, permanent DIC, it can be used and the bleeding will be stopped. You use all the uterine products also wherever it's a bleeding stop, and you keep the cannula for hours together. Prophylactically, if the patient is in some average rate of ether, or if the patient is taking aspirin, or he is taking some other anticoagulants, some medications may not be able to stop anticoagulants. So in that case, you keep the cannula for some more hours, so that we will stop. If there is bleeding after some time, after introducing the cannula, it could be a traumatic bleeding. So you, with the cannula, you can check the cervix or the fornix. Cervix is very easy. Fornix is bleeds, it's going upwards, then you have to catch it and control it. With the cannula, you can do it. I have many tricks for that. I use a light vaginal. So light is not a problem for me. I can see inside of, because light is in your hand. You see it he said very clearly. That's how I started my practice, this academic practice. Even when I used to do it, so you see inside, you can't even you see where it is. So there's no doubt about it. This is not possible for everybody, but still, you introduce the candle and if there is someone who check the service or check for the other players of the side of the arena going on. This has happened, that's what I said. But these things have happened. This is a case where I doesn't normal with the and doesn't get it. I thought everything is normal. But still I put the candle before the check prophylactic. But even after the check then I checked, there was a big builder from one of the provinces. It was difficult to catch. Still, I caught it. Died and but we have hemoglobin from 11 drops to 9. Oh, so it's only 9. It's okay. But because this, you have to clear this. Next day, when I check, your hemoglobin was only 7.5. Why this happens? This is the redistribution of blood. When there is a bleeding, all the vessels will contract and you will get false hemoglobin. When you check it, because all the vessels are, there's a mechanism there. When there is hemorrhage, vessels will contract and there is a preferential circulation. So, next day, there was no bleeding further, but the hemoglobin was 7.5. Then I told the patient that hemoglobin is too low. We will give you one that. Then she said to me that she is Jehovah's Sachi. You have heard of some people like that? It's one of Jehovah's Sachi. She's a denomination in Christian population. Jehovah's Sachi. Disciples of Jehovah. They don't accept blood. Oh, I got it. But hemoglobin was little more further down. What I wrote that. I didn't know. Others have done a sincere prophylactically. Things are so difficult. Then, anyway, there was no bleeding. So I carefully gave one FCM water, kept it after about 2 days, then 500 milligram of FCM on the third day, and then now she is left without. So, unexpected things can happen inadvertently, and you don't even know that something has happened. So, don't be panicked. Everything has consequences.
DNC.
DNC, your cervix is, even if your cervix is dilated, 9 millimeter, you can use a 9 millimeter cannula. I have a DNC cannula. It's radical DNC cannula. It is 8 millimeter. If there is excess bleeding, you introduce the cannula and start sucking. Connected to suction machine, bleeding will be stopped. Even the cervical pregnancy bleeding will be stopped. I have done like it. But that's not a tell you that I am doing like this, it is possible. That not only has to share because it is possible. Then, the cervical pregnancy bleeding, there are many methods to control it. Even you can put in a Foley, inflate it and pull it down. Then I have another device called cervical ripening device for induction of labor. So, put the Foley inside, put the ripening device, you can pull it down and connect it to this, so always a pressure is maintained on the cervix. So, the bleeding should be closed. A lot of techniques are there.
The incidence of placenta equita and multi-radiation placenta must be increasing because more, not because of improper use. Maybe because of this. Maybe because of injudicious use of this leafy and all this. No, they take it from the market. They take it. The chemist gives them, and there is generally something about endocarditis sort of thing. So I think these are more to be blamed for this anterior placenta than DNC procedure. Because when the doctor does a DNC, yes, we have art of everything. Everything is an art. When we are operating, when we are delivering, everything degree is enough. So there is an art of doing a suction graduation. We don't keep on doing this is like this. So, you can learn one place, the whole thing sucked out, and another, the whole thing sucked out. Then you can rotate and the things come. So somebody has a habit of putting the cannula, you not give time for the products to be sucked out, you keep on doing this, like this. So those also can enjoy, but most of the people, I think, because of intuitions and the rules, medical examination, and they causing endometritis and then the secret is there. Retail placenta. So retail placenta, when you are in the periphery, you are getting a case of retail placenta. If the placenta, the cervix closes, the cervix closes, the placenta is there, and you don't have to do anything, you can send it. You don't have the mastitis, you don't have the setup or a medical placenta, you can send it. And you just slowly. There was a patient, she came from a place. I was in OP, I was doing a cesarean section. Then she came in retail placenta. Then my DS was sitting outside. I told him, Nana, please go and see the case. And he said, the patient will die. He was already in shock. Then there was anesthesia from there. I told him, please don't check it, patient go. So he saw the patient and he brought the patient without changing anything. The whole trolley he brought inside the OT. Then I had been in blood. Her mark was so good. I said, we need blood transfusion, and tall fellow, PRCA, got 3 bloods from the blood. He was a very smart fellow. Then in the, she was not transferred to the OT table. In the trolley only, he gave anesthesia. I put my hand and got the placenta out. 3 bloods came. Then I wanted to see the attendant. I said, who's the attendant? Then I saw the husband because, comes like this. I told him, get him to the blood bank, get the blood from him also. Because we spread the message that in the periphery that you go to medical college, then get the blood from him. Then we got 4 bloods, and that was Friday, my duty had finished. I told, let her leave. Take care of her tonight. So when I went in on Saturday for the lunch, she was, bending. Like talking nicely. And I said, this is recurrent. Then she had a history of retail placenta in her previous pregnancy as well. And this time she did not come for a hospital treatment. So they forget. So I told her I'm going to wait on Tuesday, and she refused. Then when I made her understand nicely, she came and I did it. So if the placenta is not separated, so it's always better to leave it and send it. If the ossils open, there is partial separation, then you cannot send them, you have to remove.
Thank you so much, ma'am. We have also seen retained placenta cases. I'm sure all of you must have seen in that. I mean, it's just in the vaginal canal. Okay, the placenta is separated. Just that it has not been expelled outside, it's in the vaginal canal, and the patient is referred as retained placenta. But when we just do the primary examination in a labor room, we get to see that it's lying in the canal. And that's pretty easy. I mean, you can just take it out because it's already separated completely. Right? I hope you all agree. You must have got such cases which are diagnosed as retained placenta and then referred also.
You are, whenever you refer a patient to a wherever hospital, do you keep a care of what happened to the patient? Do you do that? Do you have the habit of, whenever we take the phone number and wherever they are. So, do you have the habit of keeping a tag of that patient?
That is very important.
This is very, very important. This is a learning curve for us.
Yeah.
This is a learning, we keep on learning till we die.
Exactly. That's very
true. Very important. I have sent the patient and our job doesn't end there. So what happened? This is really
we just cannot forget after referral. Okay? We really need to keep a track. I mean, all of us have mobile phones. So we really need to keep a. You don't think that after referral my job is over. You need to know, you need to learn, you need to improve on your mistakes. or not mistakes, I mean, whatever, you will not do mistakes, but just that if you want to improve on yourself, that's what I need to say. Okay, so we are sort of going from placenta accreta and then we are going backwards. Now, I would like to know on my delegates' behalf, I mean, what the experts would like to advise on the preventive steps for PPH. I mean, this is primary. Like, we don't want PPH. Forget about management of PPH. We don't want PPH to happen at all. So, can we just put some light on the preventive steps of postpartum hemorrhage?
So let us get these answers from them.
Yeah, that's good. That's good.
They are the first step. So, so they, instead of us, let us know.
Can we have inputs from the house, please? What do you do to prevent PPH? The management starts right from the antenatal period. You should remember that. It must be postpartum hemorrhage, but prevention starts right from the antenatal period. So if you can just tell me.
You have to see in the OPD. When you are seeing the OPD, every how many patients you have to see. Cannibals is there, you don't have to see all patients. You have to see only the obstetrics and gynae, So every how many patients.
Please come forward, please come here so that you are visible through camera also. Please come forward and ask. Please introduce yourself and then go ahead.
I'll stand here.
Yeah, sure.
Okay. I'm Dr. Khasi. I'm working in emergency. So for us, like we put on the checkup. We check we have antenatal days like every week. One day we have an antenatal checkup day where all the pregnant women they come to our facility and they get their checkup done. So for us, it's very important that we check for the hemoglobin. And then, of course, do correction every to decrease the hemoglobin. We also do other tests like markers, and then we thyroid test, and then we give counseling on nutrition, how to eat, what to eat, and then we've also started offering ultrasound services.
So do you offer ultrasounds to every patient who comes to your antenatal OPD? How is the practice like?
Yes, ma'am. We try to give to almost all patients.
So now since we are talking about PPH prevention, let's keep ourselves restricted to that. I mean, we'll not talk about general antenatal care. What special you do for patients you think might develop PPH? What are the preventive steps you start right from her antenatal period?
First, we try to maintain the hemoglobin.
Yes.
So that the patient is not anemic.
So this is very important. I mean, as soon as she embarks upon her pregnancy, it's very important that she should have adequate reserve. So this point is very, I mean, she should be with adequate hemoglobin so that she can withstand the process of labor.
How much do you tell the patient that we have to tell, no, your hemoglobin should be good?
What is the
cutoff? Tell them that your hemoglobin should be good. How much do you tell them?
Ma'am, this side is a very big prone area, I feel.
Yeah.
So if we get like anything like above 10 is good. 9 to 10 weeks, we still manage with injection iron sucrose.
Possible hemoglobin heat rate and heat disease also there. You know, those people with hemoglobin heat rate, heat disease,
yes, ma'am.
They may have a little bit less, no?
Yes, ma'am.
So you have to tell them to eat well.
Yes, ma'am.
Iron injection will not help them much.
Okay, so apart from hemoglobin, what all things you... I hope you're okay with my questioning. I just want to know what is the practice. That is it. I mean, the whole intention is to bring down the number of cases of PPH. That's all.
Then we also check for the parity.
Yes.
For example, out here sometimes we have, like G10, G11, 12. I've got a G18 once.
You have to counsel the patient.
We counsel the
It's a
patient,
high risk.
and we try to inform. We try to those type of patients we refer them to higher center. But right now in our facility we also have OBGYN specialist. So we'll see for. And then that anxiety and then history of any previous cesareans. For those patients also we give special care and we try to.
So do you consider post-cesarean pregnancy as a high-risk pregnancy this time? How do you label them?
Ma'am,
do you
if
consider
it's,
them high risk?
yes, but ma'am, if like it's also depends on the number of years no, from the last how I mean.
Yeah, like we have been talking a lot about the relationship of a previous cesarean section and this time having a case, having a diagnosis of placenta accreta, right? So whenever it's a case of previous cesarean section and the placenta, we find in a routine ultrasound that it is an anterior placenta, mostly over the lower uterine segment. We would definitely try to confirm whether it is a placenta accreta or not. So as we all have decided and agreed on the fact that placenta accreta is very well managed if it doesn't come as emergency, and we are well equipped and well prepared with the diagnosis. So what I mean to say is, primary cesarean section is a major contributor in the number of cases of placenta accreta that we are seeing. Like when I was a postgraduate, we hardly used to see placenta accreta, but nowadays it has become so common. So whenever we get a case of previous cesarean section, we do an ultrasound, we see the placenta is anterior, please ensure from a good radiologist that it is not a case of placenta accreta. Okay, so that's agreed. Anything else you would like to say regarding prevention? I mean, what are the steps? I mean, can we hear from other people also, or you want to continue? Whatever. I mean, I just want to know what are the steps you take, especially during labor. We talked about antenatal, booked patient, insist on an institutional delivery. All that is well taken care of. But now what I want to know is, what do you do as a part of labor management for control, prevention of PPH? What do you do?
Active management.
Yes, very good. So that is the thing we want to impress upon all, that active management of third stage of labor, that is something we need to do for every patient. I mean, considering that any patient can land with PPH, and that takes care of the problem, mostly. So what do you do basically in active management of third stage of labor?
CCP.
Okay, control contraction. I'm sure all of us are very well versed with the technique, right? Control contraction. Okay, then?
Before that,
anything else before that? Yes, before you try traction, would you like to ensure something? Would you like to ensure the uterus is contracted or not? Yes. How do you do that? How do you do that?
You try massage.
No, we just put our palm over the abdomen, right? We feel for the fundus, good contracted uterus, you will feel only it's a good contracted uterus. Right? What else? Then, do we give oxytocin? Are you using oxytocin immediately after delivery? Yes. How fast you give it after the delivery of the baby? I mean, when we are talking about AMTSL, how fast you give the oxytocin after delivery of the baby? Do you wait for some time, or is there any time? I mean, within that much time you have to push. Immediately, yes. So that is the answer. Within 2 minutes of delivery, you have to push oxytocin. What will oxytocin do? It will cause contraction, right? And then it will go ahead with the controlled contraction. So that reduces the duration of third stage of labor, and also it will reduce the amount of loss. Right? Okay. So thank you so much. Can we hear something else from other doctors here? I mean, what are their practices? that, right? So please say what, yeah. Doctor, you please come over here so that you are visible to our online viewers as well, and introduce yourself and then go ahead.
And good evening everyone. I am Dr. Arun Kumar, working as a charge in Nangal PhD. Nangal PhD is, it is border area. It's almost 100 kilometers from Shillong, proportion. So it's been quite a challenging task for us working there. So, sir, I would like to, there's a question hovering in my mind that I used to manage CPS. But whenever I go for any program regarding this CPS, that point is not being discussed. So I'm just thinking, is it obsolete? Yeah, is it not advisable to abdominal aortic operation?
I didn't get it. If you can please repeat your question. What is that question? You have been searching for an answer in many PPH workshops.
Yeah.
Tell me.
One point is not discussed in that PPS.
Yeah.
See, they are discussing about uterine massage, uterochronic medicines,
Yes.
then bimanual compression,
Yes.
then say balloon catheterizing, this and that. But this compression of abdominal aorta is not discussed. But I have heard from one senior gynecologist that I had applied it 2 times to my patient. Unfortunately, fortunately, I encountered around 5-6 PPH patients, but 2 was a bit serious. I had to refer the patient to a hair center. But I had applied that aorta compression to both the patient. I can do this bimanual compression also, then I have done this balloon catheterizing also. But by doing that and with uterine massage, I was fortunate that PPH was a bit controlled, then I referred the patient. Both the patient was safe. Is it this compression of aorta, is it obsolete now? Yeah, still we can use it.
My experience is very limited.
It can be done. Many places, many reports are there. Even manual compression of aorta will reduce bleeding. And there are instruments to clamp the aorta while doing it hysterectomy or uterine procedure to reduce bleeding. Aorta clamps are there. Aorta clamps many vascular surgeons are using, even gynecologists are using many places where they clamp the aorta to stop the bleeding.
I think that the doctor wants to know here regarding the aortic compression.
This is done.
I mean, for abdominally, what we do.
This is done by many with a fist to reduce the bleeding or the time.
Sir, I have done it 2 times in my patient before referring. One case, so I was there after with all the active management process of labor, after delivering the placenta, patient was bleeding profusely. But one case, so I was not there, but our sisters called me. It was bleeding profusely. So I was ready to do this bimanual compression, but as per the doctor, that senior gynecologist, he has said that going for bimanual compression is invasive process and very uncomfortable for the patient also. So process start with the abdominal aorta compression. For the compression with our face, just an umbilicus level, we compress till we feel the pulsation, then compress down till we stop feeling compression. Then we check the femoral artery pulsation is there or not. By checking that femoral artery pulsation, it confirms that our feels our pressure is found in that block the blood supply. That is the process I'm doing. Then fortunately, with that 2 patients we managed to save. So if this is something that other colleagues also can try, I believe. So in other sessions also, if we can get this one, then how we can maneuver the things in an effective way, if from the expert side, if they can share to us or innovate.
Thank you so much. If any of the other experts would like to throw some light on aortic compression, I mean, our doctor is really interested to know about it. Aortic compression. I mean, not the invasive one, right? You don't want to know about the invasive one. I mean, that's just abdominal aortic compression with a fist we do. So, does it help?
Temporary nature. We can send the patient to a referral center. Rather now it's an anti-pneumatic garment also that should be available in all PHCs. So it causes compression, and that's how the uterus will decrease. So by the time the patient is referred to a center where she can be operated and various surgeries can be done to diminish the bleeding. But I wanted to ask you, so you get the manual compression, you are in the ambulance all the time compressing the, for how many minutes do you keep it?
Mainly two sisters, so I tell our sisters and I, firstly I do, at the initial setup, I press around 10 to 15 minutes. I release it and see whether the bleeding is still there, then I press it, give it around 20 minutes, but not more than 30 minutes I press it.
You refer the patient? Yeah. The referral center was how far away?
It will take around at least 5 to 5:30 minutes, hours.
Yes. Immediately after the compression, that some bleeding may have reduced, but we agree that it's a temporary measure, it can be done, and after that, definitive measures have to be taken, as she said.
Definitely. Now, we have another expert who has joined, who is busy noting. She's a professor in Obs and Gynae in NEIGRIHMS, Shillong, Professor Nalini Sharma. So we would like to know from her as well, like her opinion on aortic compression. Dr. Nalini, please.
As already discussed, it is a temporary measure, and it is not going to solve the cause. Just to decrease the blood flow for some time. So I don't think so. If you have to shift the patient for the duration is more than 8 minutes. And the second thing, I think so it's quite painful also. So how much patient will be cooperative with this method? I can't comment. Because definitely it will be a painful procedure.
Okay. Thank you so much. Anything else the house wants to know? Regarding the preventive steps in PPH? Yes, doctor, please come forward, introduce yourself, and then go ahead.
I think we will people doing something and you see that you are getting some results. So people know the things. Sometimes this can be a big thing. No?
Okay, first of all, I would like to just thank everyone, especially sir. I'm so amazed with what Sir has actually been doing. It's just like an inspiration to me for the many inventions that he's actually done. He's like a scientist and also a doctor at the same time. So basically,
So I'm a scientist.
yeah. So really, sir, I just wanted to say that when it comes to the preventive methods of PPH, one thing that we normally stress in the field is also family planning. It's very important, I felt.
Yes.
That, right, it has to be started right from the time that the mother delivers the baby. Because, in my setup, I see most of the mothers coming to me with prepared, mostly. Then it's very difficult to manage these cases. And I believe that, when it comes to family planning services, it's always the female who always have to really, talked about and, counseled about, but happily be seen, talking about it. So we have a program very, much into a picture called vasectomy. So I felt like, most of the males do not want to go that. So, sir, I think, from the gynecologist's point of view, is there any other, means of intervention where a male can also go into all of these processes apart from vasectomy, apart from the invasive procedures that the male do not want to go about. So I believe, it's actually a high-end period where, like a research fraternity will also have to look into this.
So basically, you want to know about family planning measures?
Yes, the new innovative ideas when it comes to from the male side.
From the male side,
yeah.
Vasectomy.
No, apart from vasectomy, there are any other.
You don't want vasectomy.
Yeah,
you want what the females can adopt. Yes. So we have many options, right? And that depends on the
apart from the invasive procedures.
Invasive procedure, not tubectomy.
No, vasectomy. Yeah. Is there any other new thing that yeah.
You want to know the various family planning measures available for the lady?
Apart from vasectomy.
Oh, for the male, apart from vasectomy.
Because I believe that that's also one of the preventive measures when it comes to, FTC, because if you go further along, what would actually help a female to not develop AIDS. And another question I would actually encouraged by the analytic document. So I just wanted to know if there are any evidences on the risk when it comes to cannulation and uterine perforations while performing the procedures, especially at the periphery levels.
Or for use of suction cannula, any complications?
No, ma'am, risk of uterine perforations.
Perforation? No. Okay. So perforation is there.
No, it cannot perforate. The awareness must be very strong. You don't think that you are probably.
Because it's a postpartum uterus.
No. Contract as soon as suction starts. Then this is more than a 12 millimeter cannula. The biggest cannula that we use for suction curettes. 12 I made this cannula first with the 12 millimeter cannula, plastic cannula. So you cannot perforate. However strong you are, because once you start suction, you will feel contract. It becomes smaller and harder. You cannot.
Thank you, sir.
Regarding the male contraception, one study is going on RISU.
I want to know about
that RISU, actually, the complete name I can't comment, but yeah, something is going on.
I want to know about that.
RISU, 8% I can't comment, but it is, no, it's not gossip. Or something, they locally some injected, something is there, and studies is going on. 8% I can't comment, but definitely one thing is there. That is RISU, but full form I can't. Some reversible. It is for male.
I want to know something about it.
Yeah, it is there. But studies are going on. ICMR is doing so.
Thank you. Can I ask you something? Like you were telling you get a lot of atonic PPH cases, right? Could you find out what will be the reason for that? Why do you get such?
Multigravitas, mostly multigravitas, sometimes G17, G60 are coming into picture.
G16, G17.
I have G22 as well.
So how did you manage?
Ma'am, some of the time it's just like by God's grace, you were able to manage somehow. But then, it's very difficult, especially in our setup. And then we have another DMCHO who's actually, she will actually be attested to that. Counseling is a big challenge for us because they all believe that our children so we can reduce as much as possible. So mostly I feel like I do counseling, please don't treat yourself as a reproductive machine.
I want to comment here. You are telling that many patients are brain multi, and brain multi is a risk factor for PPH.
Exactly, ma'am.
Are you aware about other risk factor of PPH?
Yeah, ma'am.
Yeah. No, there are lots of, suppose patients having during pregnancy, or big size baby, or polyhydramnios, or there is a prolonged labor. So if you are getting more than 2 risk factors, so please, if you are not having blood-brain facility, don't deliver them.
Okay, ma'am.
Because PPH will not give you time.
That's true.
The patient who are having risk factor, this is FIGO. If patient is having more risk factor of PPH, they should deliver those children those are having blood-brain facility. It's like we open the tape and it is convenient. PPH will not give you time.
One thing is that in the periphery, you cannot direct the patient, they will not allow. They want to deliver their because they financially they refuse for you go say everything because it's statistics. You get one PPS cannula and one annual section of the window. It costs less than 4,000 rupees. And all grand you can see covered in the book, all grand.
Sir, I have a question for you. Actually, no, because I never used your cannula. And yeah, yeah, that's why I said. Because in RCB, if we go Foxy, in any guidance, you know, cannula is not mentioned. That's not
all these are European based studies and their practice. See, I have more than 1 lakh, 2 lakh observers US for my videos and lot of doctors in India are using and they are doing feedback. Suppose somebody is not using, is not an excuse now. I will tell you also. Then I was attending one PPS workshop and I had some presentations. BLs were there. Actually, the person who names BL future, he has done only 5 cases. Only 5 cases. And because he is a British citizen, actually he is a Negro, but British citizen, he is very senior obstetrician. She published this in British journal. He is influential when he published. Otherwise, there are a lot of questions against his publication because he is an university procedure who asked you to do, who gave you permission. But he published it and this publication was in the world. And one American lady underwent cesarean section. And she filed a case against the doctor for homosexuality. And the advocate was very clever. He filed out this literature and quoted in the argument that there is a procedure which saves the uterus in PP. That is BLC procedure. And that's why BLC became so famous. With the introduction of the PPS cannula, there is no need of BLC or any other commercial suture or stepwise devascularization. I don't know why it's not being accepted.
Yeah, that's
this is tragedy for the Indians. Yes, sure. Everybody knows, but nobody wants to do.
So we need to hold more such workshops, sir, all over, so that people get to know and then they get to use and after that.
I will tell you one more. Many workshops. Who is calling a workshop? Who is giving an opportunity for a half an hour talk? Nobody. Because it's all even the Foxy. Have you gone for Foxy conferences? Who is getting the keynote address? Who is getting the keynote presentations or the big presentations? They are authorities only. For some nonsense papers, who is benefited? Nobody is benefited. Some statistics and things like that. Most of the
Sir, I think we'll keep away from
nobody is there for to help doctors like you and
one thing I was wondering, suppose a patient, dead patient has to be got what medicines you are giving for to manage it for prophylaxis of injury?
Ma'am, everything that we have is actually oxytocin.
Oxytocin. And you don't have other drugs like glucose or so you know this patient is going to be. So for prophylaxis, we are using everything. But in such cases, you can do more than one drug.
Yes, ma'am.
Like you can give carbohydrates also and myself. We can't afford the patient to have it.
Yes, ma'am.
One last thing, and not the last thing, we can continue also. I would like to know from Dr. Lisa, how is the reference system like? Suppose they have a problem in the PHC, do you have a proper system integration and how do you go about it?
Yeah, we do have this WhatsApp group. There we contact gynecologists and mostly we send them to the village. So that is a bit referral. We have this CMS as vehicle also. So there's no ambulance because in some villages you don't get ambulances. So they come to the local vehicle and directly to Ganeshas. But that information is being given in the WhatsApp group, and whoever's having duty in Ganesha.
Madam, I would like to ask something. Like, it is necessary that every time you have to send Ganeshas or some like PSC to CSC to district hospital like that? Because sometimes we get patients that are referred like they are coming from 2 to 3 places, and meanwhile they reach here.
This is also the preferences of the people.
Okay.
But every time they say, okay, because we know sometimes, these prematurity or that they cannot handle that because of there's no people who are not that those people face. So what happens is that whenever we go to immigrants, say, oh, we want to go to Ganeshas.
Because we are getting many patients, those patients through Ganeshas.
Yeah.
If we can make aware them.
No, now we have started that. Yeah. Counseling the people. See, Ganeshas cannot get it to all.
Yeah.
There's NEIGRIHMS also. Since they don't want to go to private hospitals because of the cost. So we said, go to NEIGRIHMS also. We have people from this Nepal area. Why bypassing NEIGRIHMS, you want to go all the way to Ganeshas? We said, you can come here also. So there's no harm in coming here also, you can take care. Sometimes what they get is that they don't understand. And once they reach there, people don't understand them. There's the language problem. So this is the only issue because this we can be done. Like we try to counsel and bring them awareness every now and then. That's
Thank you so much. So what we need to stress upon here is a proper referral note is very important. A proper referral note like what you have done in your center and what is the status of the patient when you receive the patient and the status of the patient when you are referring her to higher center. That note must be very complete. So that way it helps the patient as well. And you need to communicate to the tertiary center to whom you are referring the patient beforehand. So they are also ready with the for receiving the patient and with all their procedures available. So that is one thing which is important. And apart from that, you do have the proper referral protocol system. You have a WhatsApp group. But even then, there's a position for the proper referrals. That is important. Okay. So anything else you want to know?
we want to ask ourselves what will be the cost of that PhD and
yes. So sir, what is the cost of this PhD?
I have got all the instruments. If there is time, I will show and I will spend most of the instruments. Most of them. It is only 2,000 rupees for the cannula and connecting tube and the mask. Then you can connect it to the suction machine directly. It can be autoclave and used for many more years. Because this is pure silicone, I have made it especially for that. Then, if the Meghalaya has 100 PSCs, you buy 100 cannulas. How much it costs? One cannula was the price of 2 cartridges. What is there? Nobody is doing this. Your director was saying, he did not hear me. You would have heard me. That not director, you are a medical officer of the state level. We know about this. You would have 2 or 3 lakhs rupees for this. I don't make profit on this. I am a user. I have enough money to spend on this. I am spending a lot of money on this. I am going outside for the conference of Paniker. I don't ask you to. So, this is such a simple, such an inexpensive thing, we can use. My positive thing is that bipolar it was 8,000.
So I just have to ask, so what's the take on the gynecologists regarding this page cannula?
Which one?
The gynecologist side, what do you think of the page cannula?
Nobody is using them, but how can they answer?
I never used it. But we got from somebody in our department.
It is a precision in our thinking.
No, sir, it's just such a good patient like
No. You can prevent PPS. What is that? Or you can teach people.
So like for prevention also you
Oh, that is wonderful. I showed you in a cesarean section diagnosis with TML. I have a paper tomorrow after tomorrow.
And that was placenta previa case, no sir?
Yeah.
That was placenta previa case.
Yeah, simple.
So that 1000 ml thing for cesarean is no more there. It can be as little as 50 ml.
Yeah. No, losing blood. If there is a thing which can prevent any blood loss, then why should you overdo? You need not be afraid of an anemic patient. See, we can predict, we can theoretically, we can say, many poor patients will come in the beginning, say, I have records with me, APS, theoretically, one of my one person, one doctor in Maharashtra, walked in last week, APH and DAS, tried he used my hemostatic and he has said the pictures. Like he said that he said the pictures. Thank you, doctor. This is possible with everybody. Everybody. Even in BSM, why can't you introduce the pictures online? My sister, AMs are doing this. I have told them, what 10 minute teaching is enough. Introduce, check whether it is reaching the water, check whether there is a need for adequate of patients. If there is any probability, it is traumatic weakness.
Thank you, sir. If we don't have any more questions, we would like to wrap up. Do we have any more questions?
I would like to show the instruments.
Okay. Okay, sir. So,
yes, I will show the instruments right now.
okay, sir. I would like to make an announcement here that the certificates, all delegates are requested to collect the certificate and also have lunch and then only please walk. Okay? So you have your lunch and then you take the certificate and now you can just see what sir has to show for the instruments.
Yes, done. It's informal. This is for come here.